হ্যাঁ, সবাই বলছে। দেখুন, সব প্রোগ্রামে এক দুজন থাকবে একটুখানি ক্রিটিক্যাল, ক্রিটিক্সও থাকা চাই। गुड मॉर्निंग।
गुड मॉर्निंग
आज आपको थोड़ा सा बैकअप
सर, बट वो लिंक इस पे दिखा नहीं रहा है। कोई दिक्कत। सर जी, ये वाला लिंक भेज दीजिए आप। इट्स स्टिल शोइंग यस्टरडे का।
अच्छा अच्छा, मेरे को भेजिए वो लिंक।
आप बताइए, देखिए।
अनुदीप सर को तो जानते होगे ना तुम?
ब्लू शर्ट में
जानते हो? ये तो नहीं है कि वहाँ के जेएमसी नहीं आ रहा बल्कि। और
आपका दिखा
सीन है तुम्हारे BMW ब्रांड में, वो कौन सा
तो क्या है?
तो बार बार
कल का स्टार्ट हो रहा है ये वैभव ने कल ग्रीन शर्ट
एक्सटर्नल एक्सपोर्ट की उसमें कमेटी।
ये आपका है ना? ये आपका
ये आपका व्हाट्सएप है ना? हाँ।
तो वो क्या है कि इसी ग्रुप में भेजना है?
नहीं नहीं, कौन सा ग्रुप है मैडम, बताइए।
ये
ये वाला, हाँ।
ये है। लिख दीजिए इसमें
आज का इसमें ज्वाइन करने के लिए।
दबाइए उसको।
हाँ, लिखिए जा रहा
हाँ।
आपका फोन देखिए, चल ही नहीं चलता।
लोग बोलो नहीं।
बट ये लाइव Good morning, esteemed guests, colleagues, and participants. I'm Dr. Utsav Anand Mani, Assistant Professor in Emergency Medicine Department at SGPGIML. It is my great pleasure to welcome you back for the second day of our national level webinar on quality in healthcare setting for healthcare workers. Yesterday, we had a series of enlightening sessions that provided us with valuable insights and practical knowledge to improve healthcare quality. Today, we continue our journey with more critical discussion and expert presentations. Our agenda for today include antibiotic stewardship by Professor Monodeep Sen, evidence-based practices by Ms. Gargi Das, radiation safety protocol by Dr. KJ Maria Das, disaster management by Mr. Mahendra Singh, nursing audit by Mrs. Nipin Kalal, quality indicators by Mrs. Papia Sarkar, pain assessment by Professor Shampa Sarkar, nursing documentation by Ms. Mary Cheriyil, and economic healthcare by Kalpana Lodi. We are privileged to have experts from various fields who will share their knowledge and experiences, providing us with tools and strategies needed to enhance the quality of healthcare. Let us make the most of today by engaging actively, sharing our perspectives, and learning from each other. Together, we can make significant strides towards excellence in healthcare. Antibiotic stewardship is a critical initiative aimed at optimizing the use of antibiotics to combat antibiotic resistance and ensure effective treatment with recent efforts focused on evidence-based prescribing and minimizing unnecessary use of antibiotics. With this backdrop, I request our first expert of the day, Professor Monodeep Sen, to enlighten us on this topic. Hi, Vithik.
Yeah, yeah. Bas.
So thank you, Dr. Anand Mani, for my uh, kind introduction. And at the outset, I would like to thank the organizers, especially the organizing chairperson, Dr. Tanmay Ghatak, as well as the secretary, Mr. Jui Dr. Ghosh, for inviting me and delivering this lecture before this August audience. So I'll take up the topic of antibiotic stewardship and its relation with the Hospital Infection Control Committee. Since the time is limited, I would like to take a comprehensive and yet comprehensive and a concise presentation. So our learning objectives would be to explain how antibiotic use can actually select the resistant strains of the bacteria and to identify some of the mechanisms which has been used by these antibiotic stewardship programs to actually decrease the bacterial resistance in the hospitals, describe the role of the microbiologist and infection prevention and control staff in the containment of this bacterial resistance in healthcare, which is actually the final motto of the antibiotic stewardship program, and participate actually in the formation of an antibiotic stewardship program. To introduce, actually, the discovery of antibiotics was a revolutionary event which actually saved millions of lives. But within the same year, it has been described that due to emergence of resistance, it actually reduced the effectiveness, increased toxicity and costs. And to preserve the susceptibility of these antibiotics or to postpone actually the development of resistance, antibiotics have to be used rationally. So Antibiotics, even beyond therapeutic use in humans, are also used in veterinary medicine as well as in agriculture, where antibiotics are used as growth promoters. So the clinical impact of this is to increase morbidity, mortality, extend hospital stay, and increase admission to intensive care. So types of antibiotic uses can be divided as empirical, pathogenic directed, as well as prophylactical. So empirical therapy is when we do not have the knowledge of pathogen, while in case of a pathogen directed therapy, we actually know the pathogen with the help of microbiology, and we can also know the susceptibility to antibiotics. So with that, prophylaxis can be either medical or surgical. So antibiotic stewardship is actually the intersection between the prevention of spread of resistance and reduction of antibiotic use, in which actually there is, it is based on the surveillance data, antibiotic policy and guidelines, and antibiotic management program. So why to implement the antibiotic stewardship program? It is actually due to its misuse and overuse of antibiotics, and there is actually poor antibiotic research and development. Also, you can see that there is actually 70% of animal non-therapeutic, that is as a growth promoter in animals. Then only 15% are used for therapeutic use in animals. And even in humans, for 6%, it is used for non-therapeutic purpose. So you can see that how antibiotics are being used or rather misused for even non-therapeutic purposes, even beyond human therapeutic use. So there is a role of a 30% in antibiotic stewardship program. So you can see that 1/3 of antibiotics, the duration of therapy is longer than needed. In 1/3, it is used for even non-infectious or non-bacterial syndrome. And in 1/3 of cases, it is used even for treatment of colonization. So you can see how much is the need for antibiotic stewardship program. And also 30%, around 1/3 of hospital pharmacy costs are due to antimicrobials. So Center for Disease Control and Prevention has defined antibiotic stewardship as the right antibiotic for the right patient, for the right time, with the right dose, through the right route, and causing least harm to the patient and the future patients. So I would really, and this is the core of antimicrobial stewardship. If you remember this, I mean, you will be able to understand and possibly achieve this. So antibiotic stewardship program, it can actually modify prescribing practices, can actually, if it is implemented rationally, can use to reduced and rational use of antibiotics. This program should be well designed and implemented based on education, and the measures to be used are voluntary, persuasive, and even restrictive. So we'll delve on how we can use methods. Then the key to modifying the antibiotic prescribing practices stewardship program must include the national policies, national antibiotic policies, which are given by ICMR or even the National Center for Disease Control. And there are local hospital or healthcare policies. There are even formularies and guidelines, education, effective microbiology lab support is required for preparation of these antibiograms. There have to be regular audits, antibiotic audits, and effective working relation with an infection prevention and control team for the implementation of this program. Then there have to be protocols for evaluation of these parenteral antibiotics. Even beyond oral, there are parenteral antibiotics. So it might include stop order after 3 to 5 days, and even recommendation for sequential treatment. There should be also protocol for the list of a reserve set of antibiotics. That is how to order and who can authorize them. Then local hospital or healthcare policies have to focus on antibiotics that have actually narrowest possible spectrum. Okay, which are expensive, have minimal toxicity, and least impact on the development of resistance. These are the actually policies which one should focus. Regarding formularies and protocols, the antibiotic formularies, no drug outside those, instead in the formulary should be used. Then there have to be protocols for empirical as well as targeted treatments. You remember I told you empiric means when we do not know regarding the pathogen, and targeted is self-explanatory in which it is pathogen target. Also, one should discuss the protocols for surgical prophylaxis, de-escalation of parenteral use of antibiotics, and also protocols for use of a reserve set of or reserve list of antibiotics. So finally, what should be the actually to implement? What do you want? What is our goal? So there are actually 4 goals. First is to reduce antimicrobial resistance. Second is to improve patient outcome. So this is the final what we want. We have to improve the patient outcome. We need to improve the patient safety, which is the third goal. And lastly, but not the least, to reduce the healthcare cost. So again, also there are a lot of national antibiotic policies in which legislation is required so that we can regulate their production and import, limitation of their use, to reduce over-the-counter use, and educate the general population regarding avoiding misuse and reduce their expectations from an antibiotic as a magic pill. Now coming on to the hospital stewardship program, any hospital, small or large, will need to have this type of a program, which will involve the formation of an antibiotic committee, an antibiotic management team, a formulary, guideline and protocols, which can be actually prepared with the help of department or with the clinical pharmacist, and education both to the staff, the pharmacists, and also using actually audits, intermittent audits of the antibiotic use. Then goals and responsibilities of the HICC. So since time is limited, tell too much upon the HICC, but please remember that this is the committee in which the antibiotic committee and antibiotic management committee is it is actually a subcommittee of the hospital infection control committee. So this antibiotic committee may be a part of this HICC or could be a standalone committee. In some places, there is something called DTC or Drug Therapeutic Committee. And who should be the members? The physicians and nurses prescribing antibiotics, pharmacist, microbiologist, management and administrative support is very important. And of course, members of the infection control committee and as needed others. There should be an antibiotic management team who will advise on the antibiotic use and audit prescription or introduction of a new antibiotic. And even larger hospitals can use even ID physicians, clinical pharmacologists, pharmacists, clinical microbiologists, and those who are actually authorized to use the reserve list of antibiotics. While smaller institutions can actually seek the help of pharmacist or use support of an ID physician or infection prevention control from a different hospital. Seek advice from these larger hospitals. So I will not delve too much on the microbiology lab, but please remember that all the pathogen directed, all the targeted therapy is thereby lies the use of the microbiology lab, in which will be regular reporting of the changing resistance patterns, that is the antibiogram, on the basis of which an antibiotic policy will be formed. And then within the reporting itself, there will be a restricted type of antibiotic reporting. Not all antibiotics will be reported for a particular pathogen, so as to institute the antimicrobial stewardship program and patient-specific data to optimize treatment. What does that mean? That is, we stratify the patient population into OPD, IPD, and the critical care, on the basis of which the treatment will be optimized and stratified. So as to introduce this anti-stewardship program, and the role of the clinical microbiologist is to provide leadership to this antibiotic management team. And they will be ones who will go to the antibiotic ward rounds and interpret the culture sensitivity data to optimize management. And they will also conduct the active surveillance to actually promote awareness regarding them. Even molecular methods for rapid detection and even resistance reporting will go a long way in the optimizing management and thereby the antimicrobial stewardship program. So the implementation. So we have discovered what we want and what are our goals, but how to do that? So that road will be traveled with 6 steps. First, we need the administrative support, administrative leadership, assess the situation. What do we want? So in that, we want the infrastructure, the manpower, also set up an AMS team, an antimicrobial stewardship team, frame an antimicrobial policy with system-wise indications, implement the AMS strategies. So these strategies could be front end or back end, which we will discuss later on. And finally, what we are doing now, we are educating and training. So administrative support, the name itself is actually self-explanatory. Without a strong administrative support and commitment to the program, no program can survive. Situation assessment. So to assess the situation, actually, we have to assess the supports, different type of supports which the AMS team will get. That is the diagnostic support, pharmacodynamic support, manpower support, and IT support, information technology support. So diagnostic support, name itself is self-explanatory. How is your microbiology lab? How are they providing the diagnostic facilities? Whether they have facility of rapid biomarkers or not? Whether an additional budget is required for specific investigations, and whether complete automation facility is available for reporting of culture ID as well as antibiotic susceptibility system. So rapid screening in form of ELISA, whether available or not, regarding biomarkers, especially those for sepsis, are required, and also important for interpretation of this antibiotic susceptibility testing. Step 2, what we discussed regarding the pharmacodynamic as well as the manpower support. So, of course, this antibiotic usage and will be dependent upon the pharmacists. Regarding the manpower support, ID physicians, clinical microbiologists, pharmacologists, very important, the nurses, the infection control nurses, the stewardship nurses, and of course, the fully functional hospital infection control committee, and 24/7 reporting for culture and sensitivity by the Department of Microbiology. We need actually IT support, computerized order entry. I mean, without actually data analysis, we won't be able to calculate antibiotic use and further strategy. So IT support is the one which is really critical in that part. I think rest of the things most people might do, but if there is no IT support, I mean, this will go a long way in actually supporting the AMS program. So also to frame the antibiotic policy, there have to be, I mean, we have to frame a handbook of antimicrobial use. Then we have to actually term down the reference points and also reach a consensus between intra-unit discussion and interdepartmental discussion. That is multi-discipline. All the stakeholders must discuss what the antibiotic policy should be. Is not actually the prerogative of any one department or any department. That is, they all the stakeholders must be on the same page within the department and even with all the departments. And of course, coordination is very much required to arrive at the consensus. So that also has to be there. Then I told you regarding the front end strategy and back end strategy. So front means actually immediate formulary restriction. List of restricted antimicrobial agents is served immediately. That is one who will requisition any reserve list of antibiotics will be refused. So that means you can understand the front end refusal to use those antibiotics which are in the reserve list. Okay. And only those who are authorized to use this reserve list will be able to do so. Right. So formally, and the role of pharmacy is that they will have to keep one prescription and send a copy department to the AMS team for audit report also. So this is the front end, which although seems ideal, which is, but then again, highly, I mean, you can always understand it is not always possible to do so. What is more tedious but doable thing is the back end strategy. So what the AMS team does is that it reviews the antibiotic use prescriptions, the prescription audit in 1 month and analyzes the appropriateness of the antibiotic use, choice, dose, route, duration, which you remember is the definition of the antimicrobial stewardship. And then it analyzes, is the decision taken and rationally or not. And this is what actually is the back end review, that it reviews the indication for antibiotic and compliance with the antimicrobial stewardship policy. What else does the back-end strategy review? So it will also review the culture reports, the de-escalation, conversion of this antibiotics from IV to oral, any adverse drug reaction or requirement for dose adjustment or renal adjustment. Then, as we are doing now, is the educational programs like formal meetings or lectures. I mean, for all the staff, for the quality stewardship nurses, for infection prevention control team, these have to be conducted regularly, and also clinical rounds with antibiotic management team or a IPC team should also be arranged. This has to be done by a senior member of antibiotic team, and this should not be provided by individuals from a pharmaceutical company. A member unless a committee or antibiotic team member is present with. So this was regarding the education and training. I mean, basic knowledge and of infection control, best practices should be there. And as I said, all, even the medical practitioner, pharmacist, nurses, junior residents, all should receive this training. So, but even with this training, you have to evaluate whether the training was effective or not. So you can use the pre and post questionnaire. We can give them completion certificates and even case scenario based test. And finally audit. So we have to monitor the compliance, whether antibiotics are used in accordance with approved protocol or not, and whether any prophylaxis guidelines are being complied with regarding to type of antibiotic, timing and its dosage is complied or not, regarding consumption data, signed prescription audit, and usage data based on defined daily dosage based on patient bed days or divided by the length of stay. We have to also monitor the appropriateness of the antibiotic, whether the policies are being used appropriately or not, dosage, timeliness, and appropriateness. And with audit data, they have to be regular and timely feedback. Need to be discussed during the antibiotic ward rounds. And we have to also assess efficacy of guidelines and protocols before a regular review. So regarding this evaluation of antibiotic stewardship program, so I will only name them because there is actually paucity of time. So there is a process indicator called policy adherence indicator, which is actually called the antimicrobial stewardship audit. So first, next is the antibiotic usage outcome indicator. There's the antimicrobial resistance outcome indicator. Then there are also clinical outcome indicators like morbidity and mortality. And finally, the financial outcome indicators. So on this basis, you will be able to actually evaluate the success or the compliance of the antimicrobial stewardship policies. So these themselves are quite extensive. I think we can skip some of them. With the clinic, I think you would be understanding some of the clinical outcome indicators like the length of stay, surgical site infection rate, which you will also remember that which can need surveillance for up to 30 days, and in case of implant up to 90 days. Then also the ward to ICU transfer rate, antibiotic, any toxicity or drug reaction, rate of C. difficile infection or death due to sepsis. So these are some of the clinical outcome indicators on which you will be able to audit, and these are the indicators which will show whether AMSP is viable or not. So there are global and even national AMR surveillance. Many institutes like CMC Vellore, AIIMS Delhi, JIPMER, and PGI Chandigarh, they are actually covering this antimicrobial resistance surveillance. So additionally, actually, the microbiology department's hospital antibiogram is the basic unit on which we have to build up our antimicrobial. First, the antibiotic policy, and then the antimicrobial stewardship program. So this is all regarding my lecture on the antimicrobial stewardship policies. So we have discussed the definition of antimicrobial stewardship. So it is the right drug for the right organism, for the right patient, for the right duration, through the right route, and causing least harm to patient and even to the future patients. So please remember this definition. On the basis of this definition, you will be able to understand how to do it, what are the committees or what is the manpower, how to do it, what are our goals, how we will be able to effectively monitor it and evaluate its effectiveness and compliance. Thank you so much for your patient listening. And again, I would like to thank the organizers for giving me this opportunity. Thank you so much.
Thank you, sir. There's one question, sir. Someone is asking if the isolation rooms are not available in HCG, then how can we isolate the patients tested positive for MDRs? MDROs.
MDR isolation room in case of, but actually it's not, I mean, we are actually talking about antimicrobial stewardship. This is regarding the contact, I mean, precautions. So I think
If referral facilities are there,
isolation is needed for this patient, MDR bugs, MRSA, MDR TB patient. We need isolation. If one corner bed can be provided. Secondly, referral is another option to higher center or specific center like India dot center.
There is one another question. Where is- So someone is asking, so microbes develop resistance. So, and the drugs which are not relevant today. So will they become relevant after 100 or 200 years? Because microbes change with time. I mean,
Okay, so so that day is actually already, I mean, people are predicting, but then actually you see, there are a lot of strategies for that also. That is why we are discussing how to do it, whether antibiotic rotation, the even new molecules are coming up for them. So, I mean, we have to be actually timeline of 200 years or that, I don't know, but then with rational strategies, as we discussed in antimicrobial stewardship, for that we need to preserve their susceptibility and use them rationally. We should not use them for I just told you now about 70% of antibiotics are being used for non-therapeutic purpose. So it's one gist is that if we use them rationally, with the use of antimicrobial stewardship, I think we'll still be able to fight them off.
thank you, sir. Thank you for sharing your knowledge with us. Now I request Dr. Tanmay Ghatak, sir, to present our respect with the token of appreciation. Yeah, that's right. Moving ahead. Evidence-based practices in healthcare emphasize the integration of best available practices with clinical expertise, aiming to improve quality and patient outcomes, which empowers healthcare workers to make informed decisions and enhance care delivery. We now request our next speaker, Ms. Gargi Das, to please take the stage. Ma'am, please.
Hello, everyone.
Good morning, ma'am.
Good morning. Hope I am audible.
Yes, ma'am.
My PPT is visible, right?
Yes,
Thank you so much. So, yesterday I had a session. Today, again, I am having one more session. Thank you so much for this opportunity again. So,
Thank
if we see evidence-based practice, lots of research activities are happening in our healthcare sector daily. Some in foreign, some in our own country. So there is different kind of knowledge is coming. There are different kind of treating modalities are coming. So evidence-based practice, what it is doing basically. So it is basically taking the best scientific evidence to the best clinical experiences, and it will value the particular patient. So what patients require, according to that, the healthcare workers will take the best evidence from the long lots of research, and it will implement it to the patients for the better outcome. So if we see, this is clinical expertise plus best research evidence plus best value to the patients and preference. If you see the definition of evidence-based practice, it is a process of making clinical decision based on the evidence combined with clinical experience and patient expectation. So patient's expectation is the important key of evidence-based practice. If I am thinking it is okay for the patient and patient is not ready to accept that, then we can't call it as an evidence-based practice. Patient side also, acceptance should be there. Patient's value should be there. And research and evidence-based practice, if we see, these are all in the table. In one line, if I'm telling that what is research and what is evidence-based practice, research is basically I am gaining knowledge, I am validating my data. But in evidence-based practice, there are lots of research done in the same topic, but from that same topic, lots of research, I am taking one or two best evidence for my particular scenario, my patient, my group of patients in my locality or my hospital, which is best applicable. So it should be like, it can be cost effective for the patients. It can be feasible for me, my organization. So research can be done for one part. From lot of research, I will take one part of one thing and do the evidence-based practice. If you see the aims, so it will provide the high quality and most cost efficient care to the patient. It to advance the quality care in the healthcare among the healthcare worker, to increase the satisfaction of the patients, to focus on practice away from habits and traditions. So we have one thing, as I am a nurse, I have seen that we always try to keep ourselves in a comfort zone. So we always try to practice the traditional way. But if we start focusing on evidence-based practice, so it will be very good for us. It will be an updation for our practices. It results in better patient outcome. It contributes in science of healthcare, and it keeps the practice current and relevant. As I have told, it will be update our practice. It increases the confidence in decision making. NESFEC is same as the it for the best possible service we need to give to the client. It updates the knowledge and it is excellent for a lifelong learning for the healthcare workers, providing clinical judgments and improving the care provided to save the lives, to provide framework for understanding the evidence-based practice and process. So components, if we see, first is clinical expertise, research evidence, information for the practice context and client's value and circumstances. If you see the evidence, when we are telling that evidence-based practice, so there is a hierarchy of the evidences. So there is a basic evidence, then there is a high quality evidence. So if I'm telling the basic evidence, those are will be, there is no human is involved or no design, proper design is there. So animals and laboratory studies can be there, case report, case series, narrative studies, editors, all those things can be there. If I'm telling now little mild, good kind of evidences, when I'm saying there is observational and there is randomized control trial. So these are the primary studies. We will tell this group as a primary studies. And when I am going the upper high level of the evidence, those are meta analysis, systemic reviews, and clinical practice guidelines. So here we can find n numbers of studies and we can collate, we can see what is the best for my patient in my particular scenario. Steps, if you see, this is the overall step actually. So I will have a question. There will be a problem in my hospital or in my organization, in my ward, for my particular patient maybe. So I need to develop the question first. After that, I have to find the evidence. Multiple evidence will be there. So multiple resources I have to go and I have to find the evidences. Now it is the time I have to scrutinize the evidence and check the strength of the evidence and which will be best applicable for my scenario. After that, I will choose the evidence and apply in my scenario for my patient. And I will evaluate the application. If it is okay, then I will continuously apply and I will generalize it. If it is not okay, then again I will come back to the first step or second step and I will do the entire circle again. So step 1 is basically based on the PICOT, P-I-C-O-T. In P is my patient or population or the problem. I is interventions, that is the variables. C is comparison. So in a study, comparative group can be there or not can be there. In an evidence-based study, maybe I will do only one group study, maybe I will do 2 group study or 3 group study. Outcome, obviously, all the evidence-based study I will think there my outcome should be this. Or if I'm thinking of pressure ulcer prevention, so my expected outcome will be there will be no pressure ulcer among the ICU patients or what patients or the geriatric patients and time bound. So it should be time bounded always. So if I'm seeing the PICO is always same, but the T, if I'm seeing here, triple T is there. So T, what kind of study I want to do? For another T, type of the design I want to find. For T, again, time of the study, time for the study, for how long I want to do. For the patient who are there for 1 month, for that patients I want to do, or for 7 days, the post of surgery patients I want to do. So that time period I need to frame here. If I'm seeing the different models, so there are Stettler model, Iowa model, Rossbaum and Llama B model. So this this just a basic brief is there. So in this model, what is that? This model developed as a practitioner-oriented model in 1994. It revised in 2001 without change in its focus on critical thinking. It raised awareness about the importance of applying research findings in nursing practices. And if we see the meaning of evidence here, evidence is defined as the information or fact that are obtained systematically. Evidence comes from 2 different kind of sources, that is external and internal. So if I see external and internal sources are basically when I am taking some other theses, some other people study, I am observing or someone have given me a note of their work, or I have seen a case study can be an external evidence, but internal evidence is in my area, I have observed, I have developed something. So these are the internal evidence for me. So in this, okay. So if I'm seeing the model, the phase 1 is for preparation, then validation will be there, which evidence I am taking, I have to validate that. Then comparative evaluation of decision making will be there. Entire evidence-based process is based on decision making of the healthcare provider. Translation of application and then the evaluation of the entire process. If the evaluation is okay, then it will be continued. If not okay, then again it will be come to the preparation stage. Iowa model is successfully implemented in 1994 and it is influences the research into practice into the improvement of quality of care. It plans to change the principle integrated to research and practice utilized in multidisciplinary team approach. So if we see the highlights, basically it incorporates the use of research and other form of evidences. Interference of the support of evidence use might involve every level of the organization. Evidence-based practice is linked to quality assurance. In the QIPs, we can use this model actually. And staffs are given recognition for their research work. clinicians are given time and resources for the research work. This model is explained how organizations change the practice based on the research. It gives systematic design and it includes both practitioner and organizational perspective. It provides the guide for regarding the implementation of evidence-based practice. Rosbaum and Larrabee model, if you see, it developed in 1999 based on the theoretical and research literature. So here, theories and literatures are more important. It being with the assessment of the need and integration of the evidence-based protocol, focuses on the use of change of theory principle of research and standardization of nursing nomenclature. So like here, if I am telling here, basically the previous, if I am thinking Betty Newman's theory, so I will reform the theory here. I will not completely change a proper procedure, but the theory I will change here. So if you see here, the need assessment for need change, need of the change, link problem intervention and outcome, synthesis the best evidence, design the practice and change, implement and evaluation, change in the practice, integrate it and maintain it. If it is not happening, then again we have to come back to the first step. So advantages, if you are seeing information, it explores the information, it provides a better patient outcome, as we are always telling that evidence-based practice without the patient's value, without the patient's experience is it can't happen actually. Evidence-based practice increases the efficiency of healthcare workers. It increases the decision-making power of the healthcare workers by based on their knowledge, and it helps the nursing practices to follow the new trends and update their guidelines. It provides the variation of practice because it can be determined the high quality, cost effectiveness intervention in actual work. It promotes the high quality and cost effective intervention and treatment. Using of evidence-based practice in the care setting of patient will always increase the confidence of the healthcare provider along with the patients also, patients' confidence on the healthcare services. But there is barrier also. It is not always, it is very smooth going in our setup of hospitals. If I am telling in Indian setup, it is not so smoothly going because there is, first of all, in our scenario, in our geometric areas, if I am telling, so more evidences are not there, more research theses are not there, practices are not there. Bringing a change is very difficult in our situation. Lack of administrative support, lack of knowledge, lack of time for the research. The person who or the team who wants to do evidence-based practice, they have to get a time also. And here, if you see the nurses, many nurses have not received a formal instruction in research and they lack their skill in that. So if we see the curriculum in nursing background, I am telling, if you see the curriculum, there is basically in BSc, we will have a basic introduction of the research. There they will do a basic project, maybe a survey kind of project. And if they are going to do the masters, that time they will do a individual good project. So the gap is there. Then there is a experience gap they have to do. So continuously that study will not happen. So basically that proper knowledge, proper instructions, proper study material is not available much here. Then unavailability of the research report which are not easily gathered. Complexity of the research regarding evidence-based practice, and organization have the motivation is lacking always there. And there are shortage of the role models in nursing who can evaluate their success and promote this kind of research clinical practices. So basically what happens when, if I will tell what I have seen in my scenarios or among my students when they go for any kind of projects, they face a lot of difficulty to do some kind of project. Even if I am telling mine, when I am going to do a research evidence-based practice, so there is a NHS have given one good document that for prevention of hospital acquired pressure ulcer. For hospital acquired pressure ulcer prevention, they have told this is the best way to prevent with the multidisciplinary action. So when I am going for the multidisciplinary action, there are doctors, there are nurses, there are physiotherapists, there are housekeeping, and there are maintenance. For me, this five group of people are required along with the patient. Patient is also a stakeholder. Patient and patient attender is also a stakeholder. So collecting them together and getting a nice flow chart to work with, it is very difficult for me. So in these cases, always we come back, we always try to go one step ahead and again we come back. So we need lots of support. Obviously, now current era, so multiple hospitals are trying to do this evidence-based practices and they are coming with new theories. Hope we will go in the future, we will do much more better for our country and we can develop our own research practices which will be valued in abroad and which they can use as a evidence-based practices. So that is my topic for today. Thank you so much. If there is any question, please let me know. Yeah. Or if anyone is doing any kind of evidence-based practice in their organization, because multiple people are here, from multiple organization, so it will be a very good kind of information for everyone.
You देखिए तो question YouTube question.
So thank you, ma'am. As there are no questions at the moment, thank you.
Thank you so much. Thank you so much, June, for this opportunity. Thanks.
Gargi, thank you.
Thanks. Okay, bye.
With this, we now move to the next session of our webinar. We now request Dr. Tanmay Ghatak sir to please felicitate Dr. Utsav Anand Mani sir. Sir, please. Thank you, sir. Radiation safety protocols are essential guidelines designed to protect healthcare workers and patients from unnecessary exposure to ionizing radiation. These protocols focus on minimizing risk through proper use of equipment, protective measures, and adherence to safety protocols. I now request our esteemed expert, Professor KJ Mariadas sir, to please share his knowledge with us. Sir, please.
Ah. Be written properly.
KJ Maria.
बोले ना हमारा ऑन है
Ask to unmute.
आप बोलिए
We request Professor Dr. KJ Maria Das sir to please commence.
Am I
Please.
audible? Am I
Yes, sir.
audible?
Yes.
Okay,
Absolutely.
right. Are you able to see my screen?
Yes, sir.
Yes, sir.
Okay.
The screen is sharing.
Right. Okay. So, good morning to everyone. And myself, I'm Dr. Maria Das. I had been a former professor of medical physics at SGPGI. That's how I know Dr. Harshvardhan and Juin for a long time, who work great work for the quality of patient and healthcare. So the topic assigned to me is radiation safety. Okay. So I would like to cover in this lecture what is radiation safety and what are the preparedness, how we should do, and what are the protocols by which we need to respect the constraints and the threshold values so that the radiation staff who are working in healthcare as well as the patient are safe, so that if we talk about the staff is safe radiation so that they don't have any genetic effects. And if we talk about the patient, they have been given a radiation therapy which is safe so that they don't have a secondary malignancies or something. So with that context, I'm going to talk about radiation safety. We all know radiation started by the discovery of William Conrad Roentgen in 1895. And after that, Madame Marie Curie invented the radioactivity in 1898. And it's been more than a century. Although radiation therapy initially started in a crude way, over a period of time, it has come to a we learned from all our lessons and we have made all the protocols. And today we can say radiation delivery and radiation diagnosis has been put into practice, which is reasonably safe. Okay. So in this lecture, since there will be audience who may be new to this field of radiation, so I will just talk briefly about what is radiation, what are the effects of radiation, and since all radiations are not harmful, only ionizing radiations are harmful, and those ionizing radiations, we have certain maximum permissible dose limits. And what are the dose limits for radiation worker and public? I will explain. And I will talk about the safety for the radiation staff as well as the patient and what is radiation monitoring and the regulatory requirement. So briefly to say, radiation, like a sound wave or a microwave, everything is a radiation wave which can pass through at the speed of light. The only difference is that wavelength and frequency keeps changing. You look at this wavelength is larger when we talk about general radiation. As we go more towards the ionizing radiation, which could be slightly harmful for the reasons which I will explain you later, the wavelength decreases and the frequency increases. So we can classify radiation into two things. One is non-ionizing and ionizing. What are the things considered as non-ionizing? Even a simple light, microwave, or non-ionizing. Now, what are the non-ionizing radiations used in healthcare? Ultrasound, MRI, they are also non-ionizing radiation. And what are the ionizing radiations? Any X-ray, CT, MR, angio, all are ionizing radiations. PET-CT uses radioisotopes, which are also ionizing. So this again talks about the same thing. Electromagnetic radiation is there and it's a huge spectrum. The dividing line is after infrared and ultraviolet, the ionizing radiation starts. And ionizing radiation, a simple energy which we use in an X-ray machine, is different than a high energy which is created from a linear accelerator or a reactor, Baba Atomic Research Center, where they produce radioisotopes. They are very larger. And even our cosmic radiations are very high in energy. Another thing we have to keep it in mind, can we get away from radiation? Hello? Can anyone comment? Can be there any zone completely radiation free? It is not. Because you see, there are cosmic radiation in the entire globe, and our Earth has a layer to filter these cosmic radiation. Still, we have a considerable small amount of cosmic radiation. And the food what we intake, the rocks, because radium, thorium, and other natural radioactive isotopes have been there. And because of radium decays that it produces to a radon gas, and these gases can be inhaled by people, and many of the things is there in the rocks and soils which gets into the vegetables, and as a human being when we consume we also have potassium, and those things get into our system. So we cannot be completely zero free of radiation. So what is the major contributing factor for a radiation? When I talk radiation, please remember it is ionizing radiation only. It doesn't take into consideration the light or the microwave or the other radiation what we absorb, because those effects are very minimal. They doesn't produce any chromosome aberration or any other health hazards as much as the ionizing radiation does. So the largest contribution is the natural background radiation, if you look into it. Because of the cosmic food and other thing, the general overall globe mein world ka average radiation is 2.4. Just assume this factor as some unit, which we call it as sievert, is the unit for radiation protection. And when we talk millisievert divided by 1000, so 2.4 millisievert is the radiation annually which comes from background. And this background radiation may differ place to place. Like for example, if you go closer to Kerala, the background radiation will be little larger because वहाँ का hills and rocks में थोड़ा radiation content ज़्यादा है, radium thorium. So similarly, if you go across the globe, you will find it at different places, different radiation. Maybe in Japan, there will be a little higher background radiation. So remember. So now this our average 2.4, every human being who lives in this globe gets receiving. So now keeping this in mind, background radiation, we assume that, okay, let us consider as a whole figure, 3 millisievert per year is the background radiation, which no one can wish to wash it away because we will be receiving it wherever we go. Now let us compare this with a chest X, because often in healthcare, whenever we go, the first diagnostic investigation is that have a chest X. So doing a chest ray, how safe it is? Is it safe? Certainly it's very safe, because a chest X-ray will have a radiation of 0.02 millisievert, which is almost 3 days of a background radiation. So now you can understand with this idea, what is the significance of our chest X-ray radiation to a patient compared to the background radiation. So it's hardly anything. But does the thing happen same true for abdomen or chest X-ray? No. Chest X-ray, you get 8 millisievert, which is almost like 3 years of background radiation. Got it? I would be happy to interrupt in between and answer any questions. Okay. So coming to this, again, radiation can be in the form of X-rays. Radiation can also be in the form of heavy particle radiations, or it can be from a radioactive material. It could be a natural radioactive material or radiation-induced material created from the Baba Atomic Research Center in the reactors, which often we use like iridium, cobalt, cesium for external radiation therapy in the thing. Or in nuclear medicine, we use FDG, we use FDG, technetium, molybdenum. Those things are being used. Iodine 131 for thyroid treatment, etc. So there are a lot of man-made radiation as well as natural occurring radioactive material. So there are two different things one you have to understand. What is the difference between a radioactivity versus a X-ray? So radioactive material always emits alpha, gamma, beta. So gamma radiation are the one which is more penetratable and its effects are there. And this The disadvantage of radioactive material is that they decay, because any activity, if it is 100 in strength, we call it as half-life. In one half-life, it will decay to 50 strength, then 25, then 12, then 6.25, then 3 point. So it keeps decaying half of its value depending upon the half-life, and the half-life of radioactive material can be from minutes to thousands of years. Like radium chelate, it is 1620 years half-life. So you can remember, if a radioisotope is there, it will be always providing radiation to the entire globe. That's why we are trying to now collect these radium isotopes, and they have been variegated and buried under the sea with lot of safety and security. Okay, so just a take-home message is that radioactivity decay keeps decaying. It never reaches zero, but beyond 3 or 4 half-lives, it becomes insignificant. The radiation becomes insignificant compared to its original strength. So when we have this radioactivity, remember, this is all-time radiation. That is why of late, many of the radioisotope like cobalt external therapy machines have been changed to linear accelerator. The advantage of linear accelerator is that when the electricity is switched off, there is no radiation. So for radiation safety point of view, having X-ray is much more safer than having a high active radioisotopes like cobalt and other things. But that doesn't mean small radioisotopes like iodine-132, where the energy and the strength is less, or nuclear medicine, when we use very small radioactive isotopes, they can be very well used, taking care of the radiation safety guidelines and practiced very safe, no issue. So just to say about the penetratability, you can remember alpha can penetrate it in a piece of paper. So radiation protection is very easy, but the intensity of the alpha to produce a health disadvantage, the chromosome or the genetic effects will be much larger. The radiation damage could be larger. So beta can be prevented by a small perspex, whereas gamma cannot be prevented. It will travel through anything and everything, whether it's a concrete, lead, or hematite building. So depending upon the energy and other thing, we calculate the building thickness, which I will try to explain in some of my later slides when I talk about the layout of radiotherapy. So one more thing you have to keep it in mind. Different isotopes have different energy characteristics, and the rays, what comes out of them, which is the alpha, beta, gamma, they have a different type of a biological effect, which we call it relative radiation biological effect. For gamma, if we consider 1, for neutron, it could be from 5 to 20 times, and alpha, it could be 20 times, which indirectly means alpha, if you give 100 units, there will be a damage equivalent to something like 10%. Whereas if you give neutron 100 units, the damage could be 200 times. So that is what is the biological effect. That is why this unit has been discovered, which is Siebert, which neutralizes and calculates the radiobiological. And also one more thing you have to remember, the human body, the gonads are more sensitive to radiation, eyes. So certain organs which are more sensitive, we have another weighting factor for the organs by which we calculate and try to determine a whole body dose as well as dose limits for each organ. So this job has been done by the IAEA, International Atomic Energy Agency, which is in Vienna. That is the global standards. From there, we derive out national standards from our Atomic Energy Regulatory Board, and they stipulate the guidelines and the protocols and the dose limits for healthcare or even industry radiation safety for our country. So I don't want to bother you with these units, but now coming to what radiation can do. Okay, it is little harmful, but what can it do? Radiation has been extensively used in medical facility, whether it's a radiotherapy or a radio diagnosis for investigating diagnostic procedures. Nuclear medicine does diagnostic and therapeutic services, and nuclear reactor to produce radioisotopes, to do blood irradiation, to do even a lot of non-destructive testing, like industrial also, radiation plays a very vital. So these are the benefit parts of radiation. When it comes to the caution, radiation can be used for nuclear weapons. And if radiation is there, radiation can induce and have a secondary malignancies. And even not in one lifetime, radiation can also be genetically transferred to the subsequent generation of your life. And if radiation is in a high quantity, it can even result in a death within 2 to 3 weeks. So radiation is really harmful, but if it has been understood and practiced following all the stipulated guidelines, it is reasonably safe compared to any other safety guidelines. So dangers of radiation is that it can affect eyes for cataract, thyroid, it can produce structural malignant or benign tumors, and for brain tumors, it can also changes your cardiovascular functions. Reproductive healthcare it can have a greater impact if you don't provide caution to these radiation dose levels. So look at this slide a little carefully. As I told you, radiation, each organs, their tolerances are different. That is why we have a radiation weighting factor to look into it. A radiation skin reaction could be that vulnerable and much more challenging to manage compared to a fire burn. So radiation burn will be more challenging compared to a fire burn. And if a person gets a whole body dose and his bone marrow is suppressed, then he will have his own other issues and he may lead to develop blood cancers as well. So now look at this part of the slide. What I told you beginning, around 2.3 or 3 millisievert is the background radiation. So if 3 millisievert is the background radiation, a single chest X-ray is only 0.1 millisievert. And what is the dose limit, upper limit maintained by the Atomic Energy Regulatory Board for all the radiation staff is 20 millisievert. So 20 millisievert is the upper limit maintained. Of course, beyond 20 millisievert also in a year, if you get some, it's not a worrisome. So 0 to 20 millisievert, and moderate risk is from 100 millisievert to 1000 millisievert. So in between these 20 millisievert to 100 millisievert, if one person has got in a particular 1 year, still it is very well safe and reasonable. So no one need to bother. The moment it crosses beyond 2000 millisievert, then only you will have high risk and you can have acute radiation sickness, which means the symptoms are vomiting, fever for a long time. If someone is having something like this and he is exposed to a radio diagnosis or something, then we can have a small BC blood test count and trying to understand what is the thing, take a history of how long he had been working and have a survey done on the equipments, whether there is a radiation leakage on the X-ray tube or somewhere, all these things. So these are all the jobs of a radiation safety officer working in any healthcare will do if you have some kind of a acute radiation sickness. And if these radiation doses goes beyond, then it could kill half of the, like if you can remember Hiroshima Nagasaki bomb blast in Japan when it happened, people who have got more than 5,000 millisieverts had half of them exposed to this were vulnerably challenged in the healthcare within 1 month, and most of them had fatal and it led to death when they exceeded 10,000 millisieverts. So this is a very high risk zone. We all practice and work within this tolerable limits. That's why if we follow this tolerable limits in the radiation safety practice, all the patient as well as radiation staff are completely safe healthcare workers. Now I'm going to just explain radiation produces 2 types of effect. That's why it's challenging. It's not easy. Like a normal light, if you switch off the light is off, there's no radiation. But these radiations, X-rays and radioactive produced radiations, they produce, it is not like once the radiation is gone into the body, it can escape and the chapter is over. It doesn't happen like that. So it can produce acute effect which is called as a deterministic effect. So this effect, when you go, the dose keeps increasing, and when it doesn't cross the threshold, you will never have any effect. Beyond that threshold, the severity of the effect increases with the dose, keeps increasing like a sigmoidal curve. So hence, this effect, if we follow the radiation safety protocols and respect the threshold, you can completely avoid the radiation deterministic effect. So very good. So if we follow the practice, then it is completely done. So it's fine. What is the great deal about radiation? It doesn't stop there. There is one more thing which is called a stochastic effect, late effect or delayed effect. The challenge of this is that this doesn't have any threshold value, and it doesn't have a severity effect also. There can be even a small amount of radiation can produce a late effect in terms of a secondary cancer or a genetically induced in the next generation certain thing if you cross, and it can produce a effect. So this is very dangerous. Hence, to do the stochastic effect, the radiation is always told no radiation is safe. Hence, even below the threshold, when we talk about radiation, we should assume the principle of ALARA. What is the meaning of ALARA? ALLARA. ALARA, as low as reasonably achievable. So, apart from respecting the threshold limits, this curve says, apart from respecting the threshold limits, even the radiation, whether it is small or large in quantities, we should try to use as low as possible, which clearly says radiation is not the first line of investigation. If you can use ultrasound, you use it. But then, do you prefer MRI over X-ray? No, because MRI is costly, because we also have to add the cost economics into it. And if you look at that scenario, a simple X-ray done to a chest or abdomen doesn't have an issue. Is that clear? So because of this stochastic effect, there is the ALARA principle, and we say no radiation is safe. So you should limit radiation as much as possible. But once you are going to get a benefit of a healthcare, then you can have these small amount of investigations done, which doesn't definitely go beyond the threshold values. That has to be monitored. So what are the deterministic effect? We all know acute disorders, fatal disorders. If someone is pregnant and exposed to radiation, they can have a miscarriage. And if you don't bother about it, they can have childs with mental disorders, and fetal disorders can be cataract, glaucoma, bone marrow depression, gastrointestinal bowel tracts. So these are all acute effects. But these acute effects can be very well managed if we respect the radiation protocols and the threshold values. What we cannot manage is the stochastic effect, which is the secondary cause of a blood cancer, which is due to hereditary. Mother had a breast cancer. Breast cancer is a little hereditary in nature. So breast cancer, if a mother had, their ancestral daughters can have. Hence, their daughters need to be screened at an earlier age and keep monitored. Okay, just as an example. So now coming to the protection and guidelines. As I said, the deterministic effect can be completely preventable, and stochastic effect has to be limited as low as possible. And these are the agencies like IAEA is the international agencies, and national agencies are ICRP and NCRP. But for healthcare and other things, Atomic Energy Regulatory Board stipulates the guidelines, and they keep monitoring the licenses for healthcare institutions, healthcare staff, and they also give the guidelines for patient care, radiation care within limits. So, what are the basic principles of radiation? Basic principles of radiation is that radiation should be used only when the benefit is larger than the risk. That's why I said, if something has to be screened, ultrasound. If you want another detailed investigation, then you look into the X-rays, whether it's a chest X-ray or a CT. Then I spoke about this ALARA principle. Doses should be always as low as reasonably achievable. The key and the buzzword for radiation protection is ALARA, and another next slide I will tell time distance shielding. And we always have to respect the dose limits, never to exceed the dose limit. And depending upon the age limits, below 18 and above 18, the dose limits are different. For radiation workers and healthcare workers, the dose limits are different compared to the public. So the different dose limits for the guidelines stipulated by AERB has to be respected in the clinical practice. So what are the dose limits stipulated? A general dose limit like 20 millisievert average over a period of 5 years, which means 20 millisievert average, but in a single year, you can get up to 30 or 50 millisievert. You need not be worried. But when it comes to public, it is only 1 millisievert per year. But this 1 millisievert doesn't include the background radiation or the healthcare ke liye when you do a CT or MRI, it is not included in that. And the annual dose limits for each structures, organs at risk are stipulated here. And when we talk about a pregnant female, whether she's a patient or she's a healthcare worker, she should not get more than 2 millisievert for the abdomen region. And if it is an intake in the form of a radioisotope from nuclear medicine, 1/20th of the annual dose limits of the radioisotope intake stipulated by the radiation healthcare. So by general, what we can say is that for all radiation healthcare workers, it is 20 millisievert per year. For the public, it is 1 millisievert per year. Now, like anything, radiation safety is also built like built-in safety of the equipment combined with the operational safety. Like if you look into a bicycle, the bicycle driving person need to know how to bicycle. He should know his road, respect the road rules, traffic signals. Apart from that, he should also know whether these brakes and other things are functional. So the functional radiation safety will be divided into two components. One is the equipment has to be calibrated, monitored. So for all the radiation equipments, they have a type approval from Atomic Energy Regulatory Board. And when they are installed initially, they are commissioned and quality assured, and quality assurance checks are being done for clinical practice. And these quality assurance checks are also periodically monitored in the healthcare sector. That is why, and when we talk about radiation, we talk about the principles of radiation is that time, distance, and shielding. All the three put together, if we practice in a safe way, you get the least radiation to the patient as well as to the staff. Because if you use the appropriate time of the exposure, the patient will get the least dose. And nowadays, advanced CT scanners and X-rays, they have dose care function, which optimizes depending upon the patient separation, whether it's a child or adult, and it gives the least radiation compared to what we have been practicing some 2 decades before. So we can always say very safely over years of time, in decades to decade, our radiation doses to public as well as the patient has been enormously decreased. So Atomic Energy and the AERB has played a vital role for us in this, and we can say with very confidence that but still this depends upon the practice of any organization, how they are going to have the radiation safe practice. I think I'll skip these things in detail because it may not be important for us to know how to practice radiation safety. But remember one thing, a small X-ray exposure will give least radiation, whereas a fluoroscopic or an angio or a angio investigation in a cath lab gives 10 times higher radiation compared to a chest radiation. So for patient dose as well as the staff working, have to be more careful in following the guidelines of using the radiation protecting device. So subsequent slide, I will be talking about what are the protective devices to be used by the staff during the radiation practice. So the person has the bedside trolley, and this is a lead glass. A person can see through this, but this is not an ordinary glass. This will filter the radiation. So we need to have bedside trolleys with this lead glass. And here also there are red glass with the C-arm facility. When a surgeon is going to do a procedure, interventional procedures, he has to be there and he has to wear a lead apron. And when he is wearing a lead apron, he will be using a personal monitoring device, which has to be wear inside the lead apron, because he is going to monitor the dose, what the radiation worker is going to get. Is that okay? So again, room designs have to be in proper order, and these room designs, the walls have to be at least 23 millimeter brick wall for a simple radiation diagnostic X-ray equipment. It doesn't end there. The doors have to have a 1.7 millimeter of lead line on the door. A simple wooden door is not adequate in any radiation instrument. So this would be of importance to all doctors and administrators. Please, when you do visit any general hospital where they have an X-ray equipment, just ask them to ensure whether they have a lead line door. Lead line door also to be put on the hinges of the thing and the closing, so that even the gaps between the door doesn't have a possibility for radiation leakage. So this is very important. So when we come to radiation therapy departments, even before the room is constructed, we have to have a layout created, which is telling like the primary wall. These primary walls can range something like 80 centimeters to 1.5 meters. Even the false ceiling will be like 1.5 to 2 meters, depending upon the energy of the linear accelerators. And also the person, the radiation worker, doesn't enter the radiation area immediately. He goes through a maze wall and then approaches this. So these are all primary barrier and others are secondary barriers. And these wall thicknesses are calculated depending upon the machine capacity and approved by AERB before even construction. And once the equipment is housed, it has a special commissioning procedure to commission and take licenses from AERB before taking the first patient. Is that right? So wherever radiation therapy installations are there, the healthcare advocates and the administrators have to check their licenses and validity of their type approval of the equipment, what they are going to use for even a diagnostic or a therapeutic X-ray services. So there will be always, you see, this is what the maze wall is of. This must be 1.5 meter. And all radiation areas have a zone monitor. And whenever a zone monitor is having a red indicator alarm telling that the radiation is beyond the threshold limit, then the alarm of the red will be there, otherwise green. So if it is red, you are not supposed to go. Even door interlocks, like all the radiation installation, will have red warning lights. And you should see this red warning light is there, then you should not open the door, you should not go inside. These are and there are a lot of personal monitoring devices like a pocket dosimeter or a TLD badges, which you often see all the radiation workers and paramedical staff would be wearing who work in close proximity to the radiation. It may be a cath lab or interventional radiology or a nuclear medicine or radiotherapy facility. And this is the symbol for radiation. This is the symbol for radiation, which will be like a circle in pink, and by this, which these there are three wings like the fan blades, which will be kept 60-degree apart, and this will be exactly in this same specification in terms of geometrical proportionality has to be maintained whenever you put this symbol anywhere. So all the components for radiation safety include that you have to have a personally, radiation workers are always trained, licensed by AER, or they will be inducted into the radiation field and they have been apprised about the radiation induction program, about the radiation safety and the work practice. And all the radiation areas needs to be monitored, and the staff working in the healthcare need to be monitored. And if you have any radioactive material, they have to be safe and securely stored with all the guidelines as per the stipulation of AERP and international bodies. And also for every department diagnostic also, there should be emergency planning and preparedness in terms of accidents, radiation. So Radiation Monitoring Act has been started in 1971, and they keep monitoring, and this monitoring doesn't happen only for healthcare. It even happens for non-healthcare and other organizations. Hello. Yeah. Okay. So these are all some of the personal monitoring devices used for radiation. And this is just a instruction for how to wear the TLD badge. TLD badge has to be always worn on the chest, because the dose, when we talk 20 millisievert to a radiation worker, we talk at a whole body dose, a chest which a good reflection for the whole body dose. And this TLD badge has to be wear inside the apron, not above the apron. And they have to be securely stored in a non-radiation environment in a department, and should not be left in the control console and other practices. And all radiation areas will have some symbols like this X-ray, that pregnant females have to inform the doctor or the technologist before they are going to have the investigation, in case if they are carrying a child or they have a potential possibility to have for a child pregnancy. So under the Atomic Energy Regulatory Act, licensing is very important, radiation surveillances are important, and responsibility of the licensee. Any organization, the employer owns the entire responsibility for the safety of the organization. And in India, the chairman AERB is the competent authority to punish or put a seal on any radiation environment if the guidelines are not followed properly. So we need to take pre-licensing stages. During the useful life of the radiation equipment, we have to monitor safe guidelines. And even after the equipment is not for clinical use, it has to be very carefully disposed properly when it is not in use. So I will just skip. So sometimes if you have a nuclear medicine and radiology or radiotherapy, you have to have a qualified RSO in every institution to monitor those. And there are gamma zone monitors and beepers, and a lot of radio quality assurance devices are there. And any hospital who is not having these devices, they need to procure and they need to monitor the radiation safety of their institutions very carefully, so that the persons who are working are safe of radiation. And this will also not ensure the safety for the staff, it will also ensure a safe practice for radiation to the patient as well. So these are the radiation symbols which could be, and when it comes to X-ray, X-ray symbol should be put like this with bilingual always, the local language and in a Hindi like this. And also these are also provided on CT or MRI or any X-ray installations. These needs to be displayed so that it is allowed. So now I would like to conclude, and the take-home message is that whenever you are working in any radiation zone area, whether it's an industry or a healthcare, remember that you have to use the main principles of radiation, which is justification. The risk should be always less than the benefit, and always use the ALARA principle, which is as low as reasonably achievable the radiation, which means if you can get an X-ray done, proper investigations in a 20 MA, you should do the 20 MA, you should not give unnecessary extra radiation, or a retake should be avoided. Dose limit should be always respected for patient as well as the radiation staff. And we use the principles of time distance shielding to have a safe radiation practice. And all the environment, the area as well as the radiation workers needs to be monitored. And there is, remember one thing, there is no safe dose of radiation, but there are limits of radiation Beyond this limit, it is very insignificant. We are very confident to say that less than 20 millisievert is very insignificant. The radiation worker has no side effects compared to any worker working on the other counterparts of the hospital. Okay, that is why radiation workers doesn't get any radiation allowances or radiation leaves today, because they have come to the conclusion this dose limit is very, very safe. But remember that be careful, but don't be fearful about radiation, because the way the international guidelines and the Atomic Energy Regulatory is monitoring is very safe for radiation, for any radiation workers or paramedical staff working in any of the radiation facilities, whether it may be a cath lab or interventional things. But follow these guidelines of practice safe. Okay. Thank you. And I would be happy to answer any questions. Did I cross time limit? Hello?
Hello, sir, there is one question.
Please.
So, is there effect of background radiation on nutritional values of crops?
Yes, it's a good question. It will be there. You see, even many of the crops, even after yields, they have been exposed to radiation like onions. Okay, for that matter. If they have been done a radiation, their longevity of life is there, and they do that. And many of the, so it is, and when they do that, it's very safe. When it is coming to that, that background radiation doesn't add anything to the patient. So those limits are safe, so we need not worry about it. Where we have to be cautious is that X-ray equipment has been dismantled, radioactive material. You all may remember Mainpuri, Delhi incident, radiation incident. A machine was being dismantled and the radioactive material has been disposed. Without knowing it, it has been gone to a scrap dealer. They opened up into the pieces and those people got radiation burn. And that has been disseminated to places. Then those kind of a radiation produces a much hazardous thing. So when we use radiation, even for food, they are very safe. And you will also remember many times you go to airport, always you are being screened by a radiation equipment, X-ray scanning. So those dose limits are very low. It doesn't produce any significant radiation damage. Am I clear?
Yes, sir.
Yeah. But at the same time, if there is a place where thorium or radium radioactive material is very rich, for example, in Kerala, some part of it is rich, and there are some vegetables grown, and those vegetable crop, when we look into the background radiation, they may be slightly high, but those radioactive material, these things doesn't go beyond a limit. Whereas the more challenging thing is that when you have a patient taken for nuclear medicine, PET scan, they have been given an oral medicine. After the oral medicine, they should be kept in a room for 3 hours or 6 hours, and then only they will mix with the other patient. And their urine and other outputs are being put on a separate delay tank and then passed on. So what in fact I'm trying to tell you is that the guidelines have been stipulated so well, all the healthcare practices or even the industry where you do food beverages radiation or industrial non-destructive testing of the planes, aircrafts, the lead sheets, they are all being tested by radiation to see any leakage. So that practices have been now very safe. So we need not worry about it. Any other?
Yes, sir. So how can we dispose the radioactive drugs and X-ray films?
X-ray films has no radiation. Okay. X-ray films has no radiation because it's a media. And today, many of the X-ray films are all in DICOM and we see on the computer viewers. Okay. So X-ray film is not. But whereas X-ray tube, what has been used, that also doesn't provide much radiation, but the disposal rules and guidelines are there. But when you take about radioisotope equipment like a cobalt-60 machine or a iridium source, their disposals are very, very stringent, and we have special type of containers and transport index. They are monitored and they are sent to Baba Atomic Research Center for safe disposal under the sea. Got it? And nuclear medicine practices are in such a way that they keep it for 2 or 3 off-lives so that the radiation becomes insignificant, and then they will open it into the gutter or something. Like if a patient is admitted, unka urinary waste or fetal waste, they are being stored in a separate containers. There will be 2 containers subsequent, and they wait for 2 or 3 off-lives, then they pass it on. So the safe practice is been advocated. They are all really safe. Only thing they have to bother about the major radiation accidents, which slowly is being happening very less. If you look at the thing, earlier, if you look at 3 decades back, even radiation accidents and other thing happened a lot. And all these things have taught us well, and those things have been implemented in the guidelines, and we have a very safe practice. But yes, we have to be very careful. But at the same time, not fearful, because a person who have taken radiation, when they come to home, you need not say, oh, you have got radiation, I should not be nearby. That you don't do. Don't worry about it. Because if the practice is safe, it will be safe. And if you have done a small CT scan, the patient comes 2 minutes after out, the patient is not carrying any radiation. Please remember that. A patient who goes for an interventional radio, like a C-arm, cath lab, or a CT, the patient is not carrying any radiation. But when the patient goes for a nuclear medicine, they have to wait for some time, then only they will be released. Once they are released after 2 hours, they are safe. Don't worry.
Thank you, sir. Thank you for sharing your knowledge with us.
Sir, thank you for your
Welcome.
valuable speech.
Welcome. Welcome. It's a pleasure to keep doing these activities. Thank you all very much for your patience hearing. And if you have any queries, also you can please write on my email or anything. I'd be happy always to answer anything beyond certain level. If you want to take it or guide anything for any purposes, I would be happy to share documentations with you for safe practice, whether it's a radiology or a radiotherapy or nuclear medicine is concerned. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you, sir. Now moving ahead. Nursing documentation is a vital component of patient care, ensuring accurate and thorough records of treatment and patient progress. It supports communication among healthcare teams and upholds legal and professional standards. We now invite our 4th speaker for the day, Ms. Mary Cheryl, for a presentation. Ma'am, please.
Welcome, Mary ma'am.
Thank you. Good morning to all. I am Mary
morning.
here from Sakra World Hospital, Bangalore. I'm working as an assistant chief of nursing in this hospital. And today we'll discuss about the nursing documentation and the importance of nursing documentation. So when we come to introduction about the nursing documentation, so nursing documentation is essential for clinical communication, and it is a fundamental nursing responsibility as well. Documentation provides an accurate reflection of the nursing assessments, changes in the patient's condition, care provided, and pertinent patient information to support the multidisciplinary team to deliver the individualized care. Also, documentation provides evidence of care, and it is an important professional and medico-legal requirement of nursing practice. So, coming to the definition of the nursing documentation. What is nursing documentation? It is the record of nursing care that is planned and delivered to the individual clients by qualified nurses or other caregivers under the direction of a qualified nurse. Also, nursing documentation is always aligned with the nursing process and reflects the principles of assessment, planning, implementation, and evaluation. It is continuous, and nursing documentation should reflect this. So when we talk about the nursing process, that means the principles of assessment, planning, and evaluation. This at the beginning of each shift, a primary assessment will be taken and it will be documented in the charts. According to the gathered information from the nurse, shift assessment plan of care can be developed in the collaboration with the patient and family cares to ensure clear expectations of the case. So after that, we will be implementing and evaluating the patient's condition, and all those things will be clearly documenting in our nurses or progress notes. Okay, so coming to the principles of the effective nursing documentation, these are the principles mainly we are telling. It should be accurate. So all the informations we are documenting, it should be specific and definite in using words or phrases that convey the meaning you wish expressed. And words that have ambiguous meanings and slang should not be used in charting, and chart always the objective facts. And next one is timeline. So always we have to follow the timelines. Examples, so whenever we are doing assessments, so there will be a specific timeline for all those assessments, especially for nursing initial and assessment. We have to do the assessment within 30 minutes and it should be documented within two hours. So always we have to follow the timelines, then only it will be accurate. Then coming to the completeness of principles. So whatever informations we are documenting, it should be complete and it should be given a clear picture of the patient's condition and what all happens during our shift. And always it should be confidential. So whatever informations we are documenting, information within the chart is often of a personal matter as well as a legal evidence of the care. And it should be available for the necessary healthcare team workers only. It cannot be disclosed to anybody or to the public. So it has to be kept confidential in our areas. So coming to the next, importance of the nursing documentation. Why nursing documentation is very important in healthcare. So first of all, it is a way of communication. So whatever informations we are documenting, that will be a continuation of the care. So doctors also are referring our nurses note whenever it is required. So that is the reason it is very important in documentation, and it gives communication to the other healthcare team members also. Legal and regulatory compliance. And also it is important for the patient care coordination with the other team members and doctors as well. Then it also gives quality improvement, patient safety, all those things we are ensuring by our documentation. So quality improvement means documentation always allows for the monitoring and evaluation of the patient's outcomes, facilitating the quality improvement initiatives and evidence-based practices. And detailed nursing documentation enhance patient safety by providing a clear record of medications administered, procedures performed, and changes in the patient's condition. And it also helps in researches and education and continuity of care. As we said, the communication is always it will be always as a continuity of care. If the proper record is there only, we will be able to continue the care also properly. And also it is giving patient empowerment and also the nursing empowerment. So that means the nursing documentation can empower the patients by providing them with access to their health information, promoting transparency and shared decision-making in their case. So we are handling different types of documentation. Examples are narrative notes. Narrative notes means our nursing progress notes, where we are documenting all the information from one by one from the beginning of the shift, and it will be end at the end of the shift. So this will be a detailed description of the condition and assessment and whatever treatment is going on and what is the doctor's instruction in that shift particularly. All those things we are writing in narrating notes. And flow sheets means there will be different flow sheets like ICU flow sheet, your vital signs monitoring chart, and your news chart. All those things are the examples of flow sheet. All those things very important in identifying the condition of the patient, and depends upon that the doctor will be further determining and deciding the care. And also we have so many checklists like we have bundle checklist and OT safety checklist. So many checklists we are handling, and all those things should be done properly. And also electronic medical records also are, many of the hospitals are having EMR now. So that is also very good initiative and we are maintaining. And another data we are handling is incident reporting. So any errors, any deviation happened, any harm to the patients, everything will be reported to the quality and safety committee, and there will be a record of all those things, and final analysis on this RCA kappa, all those things will be taken care according to the quality practices. And there are a few tips of good documentation in nursing. So always better to follow ISBAR communication. So ISBAR communication is nothing but it is the communication tool we are using to give information to a healthcare worker, another healthcare team member. So I stands for identity, S for situations, and B for background, and A for assessment, and R for recommendation. So if you follow this, it will be a good documentation in our nursing. And other tips are, it should be accurate, as we said, it should be specific, and it should be clear, and it should be concise, it should be short and brief. It should not be elaborate like essay writing. It should be always should be written short, and it should be giving a short idea of the patient, and it should be logical and sequence, and from according to the scenario or according to the order it should be written, and it should be organized, and it should be complete our notes, and always chart objective information. Example, if the patient fell down and we didn't see that patient was falling down and we found the patient was on the floor, we cannot say that, we cannot chart that patient fell down. We should always document patient was found on the floor. So this is the exact way of documenting nursing. And always try to chart immediately as early as possible after the care is completed, and use only approved abbreviations whenever it is required. And use the proper spelling and grammar whenever you are writing the notes, and better always use blue or black ink, and transcribe the orders carefully. So whenever there is a change of whenever we are indenting, so orders are written in the drug chart and we need to indent in the HIS. So when we are transcribing the order, we have to be very careful, and it should be the correct one only. We have to select the medicine, otherwise wrong medications will be selected, and dispensing and maybe wrong medications also will go to the patient. And always document the complete information about the medication. After the administration, all the complete information should be documented in our record. And chart promptly as early as possible, I said, and immediately it has to be documented. And never chart nursing care or observations ahead of time. So people used to fill the charts till the end of the shift sometimes. So these all are not correct, and we don't know what will happen to the next. So always it should be chart on time only. Then don't leave any blank spaces in the chart in between, and correctly identify the ledge entries. Sometimes nurses will forget to enter the informations, or some events happened. So you can always come and write as a late entry and write the information what was that and sign below that. So it will be considered as late entry and it will be taken. So it can be taken according to the hospital policy. So different hospitals will be having different policy. So you can follow whatever policy is following in our hospital. So always sign your full name and ID number. So after end of the each documentation, we should sign with your full name and your employee ID number. That will be great to identify the person who documented also. So any queries are there, we need to contact the person specifically, then it is very important. And duplication should be avoided. Multiple entries of the same documentation, it can be avoided. And what are the common challenges we are facing in the nursing documentation? Time constraints. Sometimes the nurses are continuously busy with continuous admissions and assessments, need to stabilize the patient. So there we are facing a difficulty in timely documentation. And when we are documenting, sometimes few informations will be missed also. So that is the main challenge. And workload. Sometimes very critical patients are there, and she was continuously engaged with one by one. There also they will be having difficulty in timely documentation and proper documentation. Technology issues, if it is Wi-Fi connection, network issues, so many issues are there. So these all are challenges we are facing regularly. Then documentation fatigue, that means continuously documenting so many things in different areas, different charts. So huge number of pages we need to fill. So these all are, we are facing the challenges. And interdisciplinary communication. So between the other team members, example, sometimes consents are taken by the doctors, and sometimes it will be incomplete, like example, date will not be there, time will not be there. So end of the each task, it is finally, it is the responsibility comes to the nurses. So we need to filling the blanks. So these are the main challenges we are facing in the nursing documentation. So how we can improve our nursing documentation quality? It is always continuously, we have to train our team, education about the importance of all those things, and sensitize them if it is not documented properly, what will be the issues and legal implications, what can face. All those things we can continuously sensitize the team, and continuous training and education can be given. And utilization of the documentation templates. If the MR is there, we can already fix the templates, and it will be easy for them to use it and save their time in all these documentations. Regular audits and feedback should be happen. So whatever documentations are happening, so we need to regularly monitor that and audit, and any corrections are required. So we need to give them corrections and improve the documentation. And integration of the technology solutions. So if EMR is there, that will be great help for the nurses for saving their time and energy, all those things. So these are the ways we can improve our nursing documentations. And in summary, I would like to say nursing documentation serves as a cornerstone of effective patient care delivery, encompassing various purposes such as communication, legal compliance, continuity of care, clinical decision-making, quality improvement, research, education, patient empowerment, legal protection, and accountability. Its importance lies in providing a comprehensive record of patient assessments, interventions, and outcomes, ensuring patient safety, quality of care, and adherence to professional standards and regulatory requirements. Best practices include maintaining accuracy, timelines, completeness, clarity, and confidentiality while navigating challenges such as time constraints, workload, technology issues, and interdisciplinary communication barriers. In summary, nursing documentation is indispensable for promoting efficient healthcare delivery, ensuring patient well-being, and fostering continuous quality improvement in healthcare settings. That's all about my documentation. Anything we need to discuss, or anything you need to add from your point of view?
Ma'am, there is one question.
Yes.
Mr. Shatrughan Parikh, he asks, please tell about the audit of nursing documentation.
That is already, we have seen in our slides, importance of nursing documentation. If you go back to the slide, will you please? Yeah. So this is the importance of nursing documentation. It is a communication way of among the healthcare team members. So if documentation is poor, the communication or continuity of the care will be affecting a lot. And these are the other importance of nursing documentation. So these all we need to follow when we are doing, like legal and regulatory compliance, patient care coordination, quality improvement and patient safety, research and education, continuity of care, patient empowerment and nursing empowerment. So these are the main importance of why we have to document the nurses notes properly.
Ma'am, it is about the audit of the document, nursing documents.
Oh, okay. So nursing documents audit will be done by the seniors or quality members. So as they are auditing, they will be able to find out any deviation is there, any informations are lacking. So according to that, they will be giving training and correction to the team members. So that is the way we will be improving the quality of the nursing documentation. I think that is you mean?
Yes, ma'am.
Okay.
Thank you so much, ma'am. Thank you for your time. We
Okay,
hope
thank
that-
you so much for the opportunity given to me also.
Thank you so much, ma'am.
Thank you.
So now we move on to our next session. A nursing audit systematically evaluates nursing care quality by reviewing documentation and clinical practices. It further aims to ensure compliance with standards and identify areas for improvement in patient care. I now request our distinguished expert, Mr. Nipin Kalal, to please guide our audience on this critical topic. Sir, please.
Very warm good morning to one and all present here. First outside, I would like to thanks to Indian Society of Critical Care Medicine and the Quality Cell Department of Hospital Administration SGPGI for giving me this opportunity to talk on very important topic that is nursing audit. Just give me a second, I'll share my slide. Okay, so nursing audit actually, if we see about nursing audit, so when we talk about nursing audit, first things come into our mind is related to, the first initially it was started with some of the financial or we can say about the data audit. So it come into the practice in nursing way back when in the Nightingale era actually, but it was not most probably uses in that in field of the nursing. Then it was come to in practice of the medical field where the medical audit has been started. And way back in 1955, this nursing audit come to the practice and it was published. Later on, it come to the practice in many of the hospital. And now if you see, it is a core part to improve any kind of the practices in hospital. So first to understand what is the nursing audit. So outline of my presentation, we'll see the meaning of the nursing audit, what are the purposes why we are doing this nursing audit, what are the components, there are several types of nursing audit, how this nursing audit will be completed, or what is the cycle of nursing audit, what are the advantages and disadvantages of nursing audit, what quality should have of this audit, and the qualities of a quality nursing auditors who are doing the audit, what quality he or she should have. To understand first what is a nursing audit, as it is said that nursing audit is a systematic critical analysis of the quality of nursing care provided within a healthcare setting. So it is very important because the first term I'm saying is the systematic. So there is some standardization will be there. There is a standard method will be there. Standard protocols will be there. And critical analysis means we have to think critically and systematically, and we should have evidence based on this. And third, quality of nursing care, what we are giving to the patient, that has to be evaluated. Now, how we can evaluate this procedure? It involves the review and evaluation of nursing processes, practices, and outcome to ensure compliance with established standard and to identify the area of improvement. Because whenever we are doing any kind of audit, so it is very important to have such documentation so that we can evaluate what kind of practices and the process are followed by the nurses. So that's why there are several types of checklists will be there in the hospital, which will be maintained and evaluated. Very important part to ensure the compliance. Sometimes what will happen, we have some of the the routine inspection or routine kind of then analysis where we used to maintain this checklist and we are evaluating. But if you do not follow properly for a long time or we do not have compliance, then this kind of audit may give the result that such practices are not going properly and we can see the outcome will not be as what we wish. And to identify the area of improvement, because whenever we are doing the audit or we are maintaining some audit report, we will come to know where we are lacking or where is the lacuna or where we are a fail. Then only we can identify the area of improvement or we can identify that gap which has to be worked on that. What are the characteristics of the nursing audit? As I said, because the nursing audit is not a simple procedure, it is a critical analysis or systematic and planned process. Because why it is called a systematic and planned process? because suppose I would like to assess any of the practice which is going into the hospital. So I personally cannot go or observe the practice whether they are doing right or wrong. For that, there is a systematic plan will be there, systematic process should be there. Keen observation should be there, proper checklist should be there. If we do have this all the document, then only we can evaluate. There should be objective and impartial, because there should be agenda, there should be objective. If I'm doing assessment, any of the part, if I'm doing maintaining the checklist, what are the objective behind that? And impartial, because sometimes what will happen in the hospital, suppose I belongs to particular area, I belongs to the emergency area. So if I'm doing my assessment in the emergency area, maybe I will be the partial. Or if I do not have checklist or I'm just observing, I can, miss the things. So I should not be impartial. It's very important. I should be impartial, sorry, I should not be partial to any of the things. If I will be partial, then I'm being wrong with or in justification with the team. So I will not able to find out where there is the lacuna and I'm not able to report it. And if I'm unable to report it, it means that this practice, whatever is going, it will remain same and they will not improve it. So being impartial, it is very important part. Continuous and ongoing. If I'll say for the sake of example, okay, I'm going to assess any of the procedure in ICU. So what will do that a team member, initially for a part of the time, they will improve their practices. They will come to know that I am a particular procedure is observing through the checklist. They will be very cautious. If for a sake of time, they will maintain it. And again, if we not do properly, again, continuous or ongoing practice will not be there, ongoing auditing will not be there, then they will not follow again in future also. So it is very important. Whatever the practices are going has to be evaluated, has to be monitored on ongoing basis or continuous basis, then only that practice will come in habit and it will remain same for a longer duration. Multidimensional. It is not necessary only the nursing part will be involved. There is a multiple team members should be there. Multiple people should be involved in that, because some of the practice where we need expert in terms of hospital administration, we need expert in terms of the different department, where we have to involve like microbiology department, we have to involve sometimes the biochemistry department, sometimes the hospital administration, sometimes the nursing team also. So it's a team of the multi-dimension and outcome focus. We in a team, if we see in the hospital, always we focus on the outcome. If we are not able to meet our outcome, then there is a problem somewhere in the system. It may be related to patient care, it may be related to quality, it may be related to some of the basic procedure, it may be related to infection protocol, it may be related to any other. So that's why whenever we are doing this nursing audit, always we see the outcome. If I would like to assess whatever the procedures are going in the ICU, and I want to see what about there is an infection protocol, whether they are maintaining or not. So on weekly basis, or maybe once in a month, they are taking the sample, swab sample about their culture. And if they found if there is a bacterial growth is there, it means that it ultimately outcome what we are measuring that the infection rate is less or not. If there is a growth of the bacteria in the ICU setup, or they take safe from the patient nurses hand culture also from the different setting, like from the bed, from the cardiac monitor, from the bedside locker also. If the cleaning procedure is not going properly, it means that our outcome is not good. So that's why always we focus on the outcome and evidence based, because whatever the procedure, protocols or policy we are making, it should have some scientific evidence. Then only this practice will remain same and we will have better outcome. So this all the characteristics are very important to have good and positive outcome for the nursing audit. Now, what are the purposes why we are doing this nursing audit? The first one, that is the risk management, to minimize the risk, because as I said earlier, if I want to reduce the infection rate, now it is very important, because if the infection rate is reduced, we are minimize the cost of the patient. We minimize the duration or stay of the patient in the hospital. We will minimize the resources. We will minimize the unnecessary expenditure. So if we follow the nursing audit, we will not make the mistake. We will have standard checklist or we'll follow them so we can minimize the risk. So it is very important to minimize the risk. We have to follow the checklist and we have to do the regular audit for the same. Resource utilization. Because as I said, if you are doing the audit, we will have standard protocol and I know what I supposed to do for a particular procedure. What kind of checklist I have to follow, what kind of the resources I have to use for this procedure. That will have proper utilization, and unnecessary utilization can be avoided. Outcome evaluation is a very important part. As we know, many of the for having the credential or the credibility, we are having many of the inspection, routine inspection, or there is a hospitals, those who require like NABH or the quality assurance for that, there's an inspection will be there. So they will also see outcome is proper or not. Whatever care is delivered to the patient, and we will see outcome. For an example, when we are even many of the hospitals are following that, they will have certain checklist or there is a certain forms that is a feedback form or the patient discharge feedback form. So in that also it is a kind of checklist also, because they will get the data from the patient about the discharge, about the feedback. So they will give their feedback whatever things has been done in the hospital is good or not. And when we are doing auditing of this discharge file or the discharge form, we will come to know where we had a mistake, where the patient satisfaction is less. So this all will help in outcome evaluation. Compliance monitoring, because why it is important? Because for the short of the time or for a particular period, if we are doing the auditing, it may give a good result, but regular monitoring is very important. Regular compliance is important. As we know, if I talk, just give you an example, if any patient is there who is having the diabetes, right? He's taking insulin or the anti-diabetic drug. If he do not take properly or a regular basis, what will happen? His sugar will shoot up. Again, it will be increasing. So similarly, whatever the checklist we have prepared, that is very important to follow for a continuous or ongoing. It should be a regular basis. Then only we can have better outcome, and this compliance should be monitored. Compliance, how we can monitor that? We can have again and again, the monitoring system. We have audit system. Then we can come to know for a particular sake of the time there was a good outcome, but now the outcome is not good. It means the proper compliance are not there, or we are not following the standard protocols. Quality improvement, but obvious, because if we have standard checklists, if we have standardized things, if we are following on the regular basis, then quality is going to improve. This quality is not only for the patient outcome, but it is for the self also. Being as a part of the professional, nursing professional, I know if I'm going to use standard protocols, my skills going to improve, my knowledge is going to improve, and my satisfaction also, because being as a nurse, it is very important when the patient is getting out of the hospital or discharge, it makes me smile on my face as well as the patient. So that is what is the quality. So overall quality is going to improve. It's going to improve ourselves in terms of the knowledge, in terms of the skill, in terms of the self-satisfaction as well as. So that's why it is very important to have nursing audits on regular basis, and it will going to improve many more things. Now there is several types of audit we can see in the hospital. The components we can see. First is the structure audit. Now what means actual structure audit? It evaluates the organizational structure of the nursing department, including staffing level, qualification, and the facilities whatever will be given. Because it is very important to have good quality in terms of the number of the staff, good quality as the level of the staff, good in terms of the qualification, as well as the facilities what they are giving. Because now we know, if we talk about the good, the tertiary care hospital, they are having quality of staff, but many simple small clinics or small hospitals are there where the really qualified nurses are not there. So this structure audit will not be able to comply with it, and there will be a failure. Second one, that is a process audit. The process audit is the procedure and the activity involved in delivering the nursing care, focusing on adherence to the established protocol. So in the process unit, what we are doing, whatever the checklist we have prepared for any of the procedures, just say for example, if I'm giving the NG tube feeding, the rice feeding, so there is a standard checklist will be there. Or I can say there is a bundles what we are following in the ICU. So there is a checklist will be there. So during giving any procedure, if they are following the protocols, what is there to deliver the nursing care, whether they are maintaining or not. So that is called as a process audit, and the outcome audit is always based on the result oriented. Result, as if I say the patient is admitted in the hospital and patient is not having any bed so for a longer duration, even though he was in hospital. So that is outcome. So now patient is not having the, the bed sore. So that is our outcome. Patient was there for a month, but he doesn't get the bed sore. Why? Because we know we have protocols to prevent bed sore, those who are bedridden patient. So that is the outcome and the satisfaction level. Obviously, once the patient is discharging from the hospital without any complication, the satisfaction will be more. As I was giving the example, like the discharge summary form, or we can say discharge feedback form will be there. So what we are taking from patient. So that is the outcome audit. So these are the component where the several part where we are taking as a part of the audit. There is a various types of the nursing audit will be there. We can classify is the internal audit and the external audit. Broadly, we can say the two types of the classification. Now, what do you mean by the internal audit? Internal audit is the audit which will be done by any of the team member inside the hospital or any of the expert from the hospital administrator. It depends what kind of audit what we are talking about it. Sometimes what will happen, for an example, if I am talking about the infection control protocols or infection control related audit or infection control management, then obviously the team will be, the expert will be from the microbiology department, or there is involvement of the hospital administration. So similarly, in internal, the people, those who are involved from the internal hospital only. Now there is again, it is classified in different types, like the retrospective audit. Retrospective audit, it means that the things which already done in the past, and now we are doing the evaluation on the past documentation or the past record. So that is called as a retrospective audit. Retrospective audit means we are going backward and we are collecting the document. Through the collection of the document, through the record, we are getting the data and we are doing the evaluation. That is called as a retrospective audit. Concurrent audit right now is the real-time base, what we are doing now. Ongoing audit, we can say that what is called as a concurrent audit. Peer review audit, it means we can take a help from our peer team members. We can ask them to do the audit, because sometimes what will happen, I may be being as a leader or be as a manager of my area, core area, sometimes I may be biased while doing the audit. But if I ask my colleague, who is from the different department, I ask him to involve and do the review. So he may, give some better, the corrections in my observation, or he may give the better idea of doing the audit where I cannot be a bias, or maybe there will be similarity. It may be what the audit I had given the report and what had been given by the peer review. So we can have compare also whether we are on same page or not. Next, called as a focus chart audit. This is focus chart audit. Particularly, we are deciding to on one kind of problem, on one kind of the issue, and we would like to focus on particular area. That is called as a focus chart audit. For an example, especially if I talk about the cleaning procedure, which will be done in any of the ward or ICU. So I would like to assess whether they are doing properly or not. So here they will observe that particular focus area on cleaning procedure, and they will do the auditing and they will find out whether it is done how it should be proper or not. That is called as a focus chart audit. So these all are the part of the internal audit, where the person who will be involved from inside the hospital, those who are expert, and they will do the evaluation of any of the procedure, any of the process or the documentation. External audit is the regulatory audit. As I said, the people, those who are from the outside of the team, they will be involved for the audit. That is called as a regulatory audit or the external audit, where the people, those who are expertise in that field, they will come and do the evaluation or they will do the audit. That is called as external audit. And as we know, we do have Kayakalp inspection, where what will be there? First will be the internal audit will be there. During the Kayakalp inspection, we have the internal audit where our team member from our hospital side only, it may be from the medical superintendent, it may be from the nursing from any of the department, it may be from the hospital administration. These people will do the internal audit or internal round, and they will prepare the audit report. Second is the peer review. That is also, we can have internal or external peer review will be there. Sometimes internal peer review, we are taking our team only, or sometimes external peer review, it means the people, those who belong to our level only, and they will come. And external, those who are expert, will be sometimes appointed by the people or higher authorities or concerned authorities. They'll come and visit our hospital, and they will do the evaluation. As we see in case of the NIH inspection, when the teams are coming from the outside, and they are doing auditing our documentation, whether whatever the reports what we are maintaining, it is as per the compliance or not, as what we required or not, or its outcome has been improved or not. So these are the several types of the nursing audit which we are doing in the hospitals. Now, what is the audit cycle? How actually we have to do it? Just for I'll give the one example and we will discuss one each point. For an example, I have identified one problem in any of the hospital area. Suppose, for an example, I identify that any of the hospital staff is not doing proper procedure. So I have identified that issues. He is not following the routine procedure, what is supposed to be done. For just an example, we are taking example here, so like cleaning. Suppose any of the housekeeping is there or any of the staff is there, housekeeping staff is not doing proper cleaning in the hospital. He don't know how to mix up the solution. He don't know how to clean that procedure, or he is doing the wrong way. So I have identified that issue. Now, what is the next step? What I have to be done? Obtain or define the standard. First, I should aware what is the standard protocol, because until and unless if I don't have standard protocol, I cannot say this is the wrong practice or this is the right practice. So first we should have the standard practice guidelines, standard practice checklist. Then once I go through my standard practice, I will understand, then I will collect the data. Collect the data means I will understand whether he is doing his procedure according to checklist or not. Then I will compare the performance with the standard. So what he has followed as a the practice or the steps, and what is the standard one. Then I will compare it. Then we can explain that these are the right practice, these are the wrong practice, and this right practice has to be implemented into the system. Once they will understand, once they will go through that, okay, this practice are important and we have to follow the standard. Then whenever they are doing following again that standard practice, we have to again observe and we have to do the re-auditing. And again, there are chances of error, there are chances of mistakes will be there. So we have to again and again emphasize this practice. And I'm very sure when we are emphasizing on the regular basis, when we are observing on the monitoring on the regular basis, it will come to the habit. And what are the issues we have identified that will be sorted out. So this audit cycle will help understand, to identify, to define, to observe, to make the changes into the system in a positive way. Then we can do this kind of the changes in the audit cycle, and this will help to make the standardize of the practice, and it will help to improve the quality of practice. Now, what are the advantages for doing as a nursing audit? First, quality improve, as we earlier also we have explained, it will surely going to improve the quality. Patient safety and risk management. As we all are aware that we are following the surgical safety checklist in the OP. So this surgical safety checklist, which is given by the WHO, and we know this checklist has many of the studies in the research literature has shown that it's reduce or minimize the complication, minimize the error because of the surgical safety checklist. And this is again a kind of the checklist or protocol, and we do the audit and will come to know there are minimize the risk. Because if we go before that checklist come into the practice, there are many news we have seen like the wrong side surgical surgery has been done, or any of the instrument has been left into the abdomen, and many more. So because of this checklist, now it has been come to the practice, and now if you do the audit, there is 0% risk we have, or 0% error we have. So this nursing audit also will have the advantage. We can minimize the patient's risk and we can improve the patient's safety as well. As evidence-based practice, as I said, because with anything we are doing, we should have scientific base. We have some protocol, and once it will be followed by all the staff, that is going to improve the quality of the patient. It has a scientific base also, and it will be adherent by everyone. Staff education and development. Very important part here is because as we know, during the COVID era, especially we have observed every day they were changing the protocol. So what will happen? Whenever we are changing anything, we have some standard guideline. Especially in the COVID era, we have seen those patients who was a positive, those who are on the risk, are susceptible to get what kind of protocols we are following. So it will not only helping to follow the protocols, but it will help improve the education also. It will help to improve themselves also, being as a professional also. So it will help in patient education. If any new staff who has joined any of the institute, or there are different types of, the protocols they are following. Sometimes there will be a institutional protocol will be there, which is somehow little different will be there. So it will help the staff to develop his knowledge as well, and he may understand now what he has to follow in the hospital. Ensure regulatory and accreditation compliance. As I given examples of the qualities council inspection also, or there is NABH inspection also, CAIATL inspection also. So if we have nursing audit record where we can show that we are having following this protocols, we have this data and we are compliance with this data, or we are compliance to these practices, and this will surely help to improve lot and lot. Accountability and performance monitoring. If I'm doing something, then I'm responsible for my action. So I will be accountable for my action, and this will give you idea that what I'm doing now. So if I have checklist, I will understand how I have to do it, and there are chances of error are very less. And whatever I'm doing, it will be monitoring. It will have checklist monitoring. So my accountability will be more, and I will be responsible for any kind of. Now, what is the disadvantage of nursing audit? Is the times and resources. Obviously, as I said, because if I would like to monitor each procedure, what the staff is doing, and nursing audit of this procedure, then it requires. Because it is not a one-day procedure, it is not a one-week procedure, it is not a one documentation. It requires a lot of time, lot of energy, and resources as well. Resistance of it. Sometimes what will happen, if you would like to make any changes, it will be very difficult because what the practices is going on and what we want to make the changes, resistance will be there at the initial level. Risk of blaming game will be there because sometimes what will happen in nursing audit. Ultimately, what we are doing, we are finding or we are critiquing any kind of things which is not going properly. So there is a risk of blame will be there. Limited scope of assessment. Sometimes what will happen here, we may limit it to the paperwork. We may limit it to the audit work. Here is one limitation will be there. Standardization issues will be there. As I said, there are certain checklists or certain procedure or certain standardized things may be differ from one institute to other institute. So there is a standard, issue may be there. So it is very important to prepare the policy protocol, and it is not an easy job because many people or many experts will be required to prepare any standardization. Limited view of nursing practices. Here is the problem when we are doing a nursing audit. So we have checklist and we will focus on the practices only or action only. Here we are missing the emotional and psychological part of the patient. So through the nursing audit, we cannot overall conclude about the emotion aspect and psychological aspect, even though there are certain checklists which will be there, but not for all the procedures. Diverting attention away from direct patient. Sometimes what will happen, we must be busy or we may focus on the, the documentation part where sometimes the direct connection with the patient or communication with the patient may be lack, or we are diverting from the direct nursing care to the documentation part. So these are the some kind of the disadvantage, but we see the advantage are many more from the disadvantage. So that's why it is very important to have. But at the initial part, this disadvantage will be there. But as the things come into the practice, as the things come into the way, this disadvantage will remain. Now, audit quality, like kind of audit what we are doing, it should be like effectiveness of audit process. So it is very important, whatever the audit process we are doing, it should be very effective. It should be without any, that means we should not be partial to any of the things. Audit firm culture. Actually, whatever the things are done, it should be have auditing on the proper time. It should be based on the proper audit, and it should be disseminated as well as skill and personal qualities of partner staff. Factor outside the control of auditors and reliability in useful audit report. It should be there. Then only we can say the audit is having high quality. So it's whatever the auditor will be there to evaluate that, they should be very impartial. They should be very expertise. They should be following the guideline. Then only audit quality will have the proper impact, and it should be disseminated properly. It should give proper justification as well as the proper, the things what we should be deliver. Now the qualities of a quality nursing auditor. Like if I am being a nursing auditor, what quality I should have first? Then I can be a auditor of this. It is not a simple person who can come today and do the auditing of it. It should not be like that. He should have some expertise in the field, then only he can become a quality nursing auditor. So knowledge of nursing standard, as I said, until and unless I am aware of any of the nursing standard, I cannot be auditor because I should know what is the right practice. Then only I can able to evaluate the rest of the things. Attention to detail. As I said, there is a minor changes will be there or minor mistakes will be there. So I have to be very attentive when I'm doing this auditing of any of the checklist. I have to see whether the things are going in the right direction or not. Ethical conduct, which is very important. We have to be impartial. We should know what our ethics say proper has to be done. Common sense and practical wisdom should be there. Sometimes what will happen when the staffs are dealing with the patient, there may be our observation may be wrong. So that's why it is very important to have some practical wisdom. When we are coming to the paper documentation evaluation as a part of the audit, we have to match the standard protocol and we have to understand our common sense as well as analytical skill is very important. We have to do the proper analysis of the documentation. Then only this audit will have fruitful evaluation. Otherwise, evaluation may be biased. Interest and curiosity. Because without interest or curiosity, you cannot come to know end of the result, or you may not able to do the proper evaluation or the monitor. It's sometimes it should not be a kind of the work which is filling up the burden or filling up the out of the interest. So it is very important to have proper interest toward this work. That's why this quality assurance or quality assurance nursing are having different department where the quality cells are especially working on this and they have good interest for this work. Communication skills are also very important because how do you communicate with the team member, how you are communicating your message, how you are communicating your standard protocols is very important. Then only they will be, following or they will adhere to that. Patience and empathy is very important. You cannot, come to the results at very short. Sometimes it may take time. Sometimes what are the protocols, it will come to the standardization practice. Everyone, it may take time. You should have empathetical approach as well as. Sometimes small error will be, maybe there from the patient's staff end. So you have to understand their concern as well as. Then only when you will come to the part of the nursing auditing, you will understand their concerns. Critical thinking, to make proper evaluation, you should be a very critical thinker. Then only you will come to the end of the part. Confidentiality management. Because sometimes what will happen, as I just gave the example, whenever we are doing any of the auditing of like protocols, infection protocols, for like they are taking the swab cultures from the department, so they will maintain this confidentiality for this among the team member only. They will not go to the hospital for such kind of practices they are doing. We have to maintain also some confidentiality which cannot be go out of the market. So that is also very important part here. So this all quality should be there. And last finally the report writing skill, because whenever we are writing, it should have that interpretation what is supposed to be, but what we want to deliver the message to the next of our team. So that only should be written. It should not be vague. It should be very crisp and critically what it's supposed to be delivered. So these are the basic quality which should have nursing. There are several papers has been published. If you go through the literature, like nursing audit as a method for developing nursing care. So they are doing on the regular basis, and this is the method which can be improved and lowered. The next article published in Identify the Impact of the Audit and Feedback on the Professional Role of the Nurse in Psychological Well-being and Integrated Systematic Review they have done, and they find that this systematic review identified that many nurses were responsive and wanted to participate in the process. So they are showing from not only from auditor as well as from the nurses part also they're showing the interest to be part of this, and then only they can improve their skill, their knowledge as well as. Next article, there is the audit to support quality improvement recommendation from nurse leaders. So in this project, the researcher evaluated the use of auditing as an intervention to drive quality improvement changes. They examined 3 initiatives to address the central and associated blood stream infection, fall and fall with injuries, and head injury. As I said, sometimes we have to focus on particular topic or particular, the procedure in which we want to improve or we want to change. And that kind of the making the documentation and the quality, the auditing will help to change a lot in the quality improvement. So here this is I will conclude my slide. Like nursing audits are the essential for maintaining and improving the quality of nursing care. If we do on a regular basis, regular monitoring, surely it's going to improve the patient care. They provide valuable insight into the current practices, highlight the area of improvement, and support ongoing professional development policy. With valuable insight of current practice, we understand that this practice is very important. It is right. Area of improvement, if you are doing wrong, it will highlight you. This practice is wrong. You need to improve on this. And ongoing professional development. As I'm doing the right practices, if I'm following this protocol, obviously going to improve my professional skill as well as by systematically evaluate the addressing gap in care. Nursing audit help ensure that patient receive best possible care. So here we will identify the gap. What is the standard practice? What is the going on? We will identify that gap, and through the nursing audit, we can avoid that gap and we can match that standard practice to the practice which is going and deliver to the patient. So thank you so much for giving me this opportunity. And if any doubt or any question, I'll be happy to answer. Thank you so much.
Thank you, sir. Thank you for sharing your knowledge with us, sir. Am I
Thank you.
audible, sir?
Yes, you are audible. Thank you so much. If any query, questions, or any submission, I'll be happy. If anybody want to add anything.
So no questions as of now, sir.
Okay. Thank you so much. Thank you very much.
Thank you, sir. Now moving ahead. Quality indicators are measurable elements of healthcare that reflect the effectiveness, safety, and patient-centeredness of services. They are crucial for assessing performance and guidance improvements in healthcare delivery. I invite our next speaker, Mrs. Papia Sarkar, for a presentation. Ma'am, please.
First, good morning, each one. And let me introduce myself. I am Mrs. Papia Sarkar. I am working as a nursing superintendent and NABH coordinator at Murugan Hospital, Chennai. So first we'll see what is quality. Quality is a hospital can be defined as a providing the right care at the right time, in the right way, and for the right person. So it can also mean achieving the best possible result. Quality in a hospital can be measured and improved over the time. Next, we'll go to quality indicator. That is my topic today. So quality is degree of adherence to pre-established criteria or standards and a statistical measurement of the performance of function, system, or process over the time. So I can tell you what is quality indicator, a standardized evidence-based practice in healthcare quality that can be used with readily available hospital inpatient administrative data to measure and track clinical performance and outcome. So there is, according to NABH, there is 10 chapters. What are all the 10 chapters? As we all know, access, assessment, continuity of care, care of patient, management of medication, patient rights and education, hospital infection control, patient safety and quality improvement, responsibility of management, facility management and safety, human resource management, and information management system. So in each chapter, there will be more than 10 quality indicators, but it is not possible to explain more than 100 quality indicators in this short duration of time. So what I'll do, I'll go through the mandatory quality indicator according to NABH 5th edition. So as we know, there is 35 quality indicator in NABH quality indicator according to 5th edition. These are all mandatory. So they have divided into 4 category, that is clinical indicator 13, managerial indicators 10, safety indicator 7, and infection control related indicator 5. So these are all the classification of indicator. So I'll explain one by one. First, we'll start with clinical indicator. So first clinical indicator is average time taken for initial assessment of patient admitted in IPD. The time shall begin from the time the patient has arrived at the bed of the ward till the time that the initial assessment has been completed by a doctor. And this should not go beyond 15 minutes. So what we can do, just in our nominal register or main register, whatever you are using, you can put one extra column and you can write the initial assessment time. Though in the end of the month, you can just see sum of the time taken. So that is the total time, and divided by total number of patients, that is your sample size. So for example, you have seen 200 patients in this month of June, and for that you have taken 2,200 minutes in a month for initial assessment. So average initial assessment will be 11 minutes. So next quality indicator is reporting error in lab. So percentage of redos in laboratory, that we have to be maintained. Number of redo sample divided by total number of sample into 1000. That is redos in laboratory. Like this, same in imaging department. Percentage of redos in imaging, percentage of imaging reports correlating with clinical diagnosis, and percentage of adherence to safety precaution by employee working in imaging. Like whether they are wearing lead apron, whether they are using thyroid shield, all we have to observe and make it a documented record. We have to keep it. Next clinical indicator is adverse drug reaction. So first we'll see what all adverse drug reaction is there for any kind of drug it may happen. So percentage of adverse drug reaction divided by number of total discharge or death in that particular month into 100. Same thing will be in account for high risk medication also. Percentage of adverse drug reaction due to high risk medication divided by total patient receiving high risk medication into 100. Fourth one is medication error. There are many types of medication error. So medication error is an event associated with the use of medicine that should be preventable with effective control system. I have mentioned some prescribing error, dispensing error, administration error. So there is lot of medication error like omission error, transcription error. So how to calculate that? Number of total error identified divided by total number of opportunities. How many patients we are giving medicine into 100. So in this medication error, self-reporting medication error and error identified during prescription audit or any other methodology shall be added in numerator. That is total number of error identified. In here, we have to identify. It may be self-reported or during prescription audit, during case sheet audit, we can identify the medication error. Next is transfusion reaction. So any adverse transfusion reaction rate, we have to document number of adverse transfusion reaction divided by total number of blood component transfused into 100. So all major and minor reaction need to write in transfusion reaction form and report it to the blood bank. So most of us, we are getting one transfusion reaction form in along with the blood bank. So we can use that form. Otherwise, any hospital, they must be having one transfusion reaction form. So all the transfusion reaction form for each cases we have to document it. For blood bank, there will be separate 10 quality indicator. It has been defined by NABH. All blood bank have encouraged to capture the data for this indicator. So out of 10, 5 indicators have been mandatory for accreditation blood bank to monitor, report to and NABH in every 6 months. We need to report that. Anybody interested in blood bank quality indicator, I will explain it later. So next is medication chart with error-prone abbreviation. So what we can do, we can go for daily rounds. Any responsible team member from quality team, any senior member, in charge, nursing supervisor, anyone can do this. Like daily rounds we need to go. Next is check all the case sheet, all the files, check all the drug chart, medicine chart, it should be in capital letter. Check for error prone abbreviation. Like doctor used an abbreviation for magnesium sulfate and wrote MgSO4 2 gram IV single dose for a 45 years old female patient, and nurse misinterpreted that order as morphine sulfate. And she wrote MsSO4 and patient received 2 mg dose of morphine sulfate. So in that case, MsSO4 is an error prone abbreviation commonly used in place of writing morphine sulfate. So we need to avoid all this error prone abbreviation. So we can note it in a register and inform to the concerned person, whether consultant or your higher authority in quality team and so. So what we should do, we need to form the CAPA form. We need to take corrective action, preventive action. Okay. So next clinical indicator is unplanned return to OT. Percentage of unplanned return to OT and in the same admission. So maybe one patient is admitted for 2 days, 3 days, 5 days, whatever it is. In that same admission, if it happens, so it has to be documented. And next is percentage of adverse anesthesia event. So what all we can do? We can do it in our nominal register or main register in operation theater. You need to put extra 2 column, and in that you can write the unplanned OT return. If anything is there, you have to mark it. And in the end of the month, you have to get the total numbers of unplanned OT return or adverse anesthesia event. The same formula like person who received, person who developed adverse drug anesthesia event divided by patient who underwent anesthesia into 100. So next is standardized mortality ratio in ICU. How it has been calculated? SMR is calculated number of observed death divided by number of expected death. That will give you the standardized mortality ratio. Next is gross mortality ratio rate, number of IP death, total discharge or death divided by total discharge and death. And 2 more indicator I would like to mention, that is return to ICU within the 48 hours and your re-intubation rate in ICU. Next is return, last 2 clinical indicator, that is clinical indicator 9 and 10. Return to emergency room within 72 hours within similar presenting complaint. It is generally assumed that patient who return within 72 hours of emergency discharge received with same complaint or inadequate treatment or evaluation. And last clinical indicator is surgical prophylaxis given within the time frame. As per NCDC, that is National Center of Disease Control, it should be within 60 minutes of incision, while as per WHO, it is 120 minutes of incision. So next we'll go to clinical indicator 11, rescheduling of surgery. It includes cancellation or postponement of surgery beyond 4 hours due to poor communication or inadequate preparation. So formula is number of cases rescheduled into 100 divided by number of surgery performed. So next is compliances rate to medication prescription in capital. So every physician should write prescribed drugs with generic name. It should be legible and in capital letter. All these things must be mentioned in prescription. So patient name, age, UHID number, any allergy, diagnosis, medication in capital letter, along with doctor signature, doctor name, registration number, date, physical activity, follow-up, and time. All these need to be included in prescription. Last one, in clinical indicator, appropriate handing over during shift change. It is an important communication tool for healthcare worker. Appropriate handover during shift change to be done separately by doctor and nurses per shift, per patient, and written documentation by each shift can be used as a guide to capture the information. So what we can do, monthly data, the total, that note itself will give you the data. Total number of handing over done properly into 100 divided by total number of handover opportunities. Okay. Next we'll go to safety indicator. There is 7 safety indicator. First one is variation observed during mock drill. So formula is percentage of variation observed in mock drill into 100 divided by total number of observation made. So note that this should be separately calculated for different mock drill like code blue, code red, code pink, etc. For each mock drill, you have to mention separate mock drill form. And patient fall rate, second point in safety indicator, it will be calculated in 1000 days. Number of patient fall reported in a period into 1000 divided by patient days in that period. Patient days, how long patient is there into your availability of beds. That will be the total patient days. Percentage of near miss. A near miss is an unplanned event that did not result in injury or illness or damage, but had the potential to do so. Next is safety indicator 4 and 5. As all of us we know, the bed sore. Number of patients who develop new or worsening pressure sore divided by number of discharge and death in your hospital in that particular month into 1000. Fifth is needle stick injury. Parenteral exposure due to any sharp, not only needle, any sharp, it may blade or suturing needle, any sharp into 1000 divided by number of days, death and discharge. So safety indicator 6 and 7. Sixth is adherence to safety precaution to diagnosis. No food, no drink inside the laboratory. Wear your PPE, proper attire, maintain good hygiene, use proper storage container, etc. Next one is adherence to prevention protocol of wrong patient, wrong site, and wrong surgery. So for that, we need to use the maintain universal precaution, that is WHO safety checklist. Regarding this, my previous speaker also told. So it is a clinical indicator whether you are maintaining in your hospital. So we can be very safe whether we are maintaining all this point regarding sign in and before incision and sign out. Okay. So next is infection control related indicator. Infection control, first point is COTI. Catheter associated urinary tract infection. COTI are the one of the most common healthcare associated infection. These infections are most likely caused by bacteria entering the body during catheter insertion. As a result, prolonged unnecessary use of urinary catheter or due to disruption of closed drainage system. So formula, the urinary catheter associated UTI in a month into 1000 divided by urinary catheter days in that month. Next is VAP, ventilator associated pneumonia. So ventilator associated pneumonia is a pneumonia that develops 48 hours or longer after mechanical ventilation is given by means or an endotracheal tube or tracheostomy. So number of VAP in a month, the formula is number of VAP in a month into 1000 divided by number of ventilator days in a month. These ventilator days, catheter days, all that it should be maintained by ICN of your hospital, and in daily basis he or she can go for rounds and take the necessary data. Next is central line associated bloodstream infection, CLABSI. It is a serious and treatable infection that occurs when germ entered the patient bloodstream through the central line. It confirmed by laboratory when a pathogen is found in a blood culture from a patient who had central line at the time of infection or within 48 hours or before symptom appear. For that, what all precaution we can take? Hand hygiene, maximum sterile barrier precaution, sterile gloves, sterile gown, mask and hand covering, full sterile body drape, skin cleansing with CAG, chlorhexidine, and avoid the femoral site when possible. So next two is surgical site infection, very common, and hand hygiene compliances rate. So surgical site infection rate, number of surgical site infection in a month into 100 divided by surgery performed in that month. Like that only we are getting surgical site infection rate in your hospital. So hand hygiene compliances rate, number of observation made in which staff complied with the hand hygiene and total number of observation made. This hand hygiene guideline must be specified. Data shall be gathered through the following. So there is a very nice form. It is available in net. You can collect it. WHO hand hygiene checklist. Okay. Next is managerial quality indicator. So there is waiting time for diagnosis in minutes. Waiting time for outpatient consultation. Okay, waiting time for discharge process and medical record with incomplete or improper consent. All that you have to document it and report. Percentage of medical records not having discharge summary, stock out of Next, again, of surgery. So number of planned surgery rescheduled or cancelled into 100 divided by number of surgery planned. This indicator can further be classified as per cause of rescheduling for the management to take appropriate corrective and preventive measure. Next is turnaround time for the issue of blood and blood components. The total sum time taken for issuing blood and blood taken for each requisition divided by total number of requisition received for blood and blood component. This time taken shall be considered from the time of receipt of requisition till the time of dispatch of blood or blood component. So next to percentage of downtime of critical equipment, total duration in days or hours for which a clinical equipment was down divided by total duration in hours or day in that period. A list of critical equipment shall be made by biomedical engineer, and this indicator shall be calculated separately for each critical equipment. Next is nurse-patient ratio for ICU and ward. So total number of nurse working in ICU in a shift divided by total number of patient in that shift. An average ratio of the month can be taken. This should be separately calculated for each shift and each ICU patient. Thank you for this. So any doubt or any clarification? Am I audible, sir?
Yes, ma'am, you're audible. There are no questions as of now.
Okay. Thank you for giving me this opportunity. I thank all organizing committee and organizing secretary. Thank you, each one of you.
Thank you, ma'am. Thank you, ma'am.
Sophia.
Now, moving forward. Pain assessment is a critical process in healthcare that involves evaluating the intensity, quality, and impact of a pain on a patient's life. Effective assessment of pain is essential for tailoring appropriate management and improving patient outcomes. Now, I request Professor Shampa Sarkar to share her views on this topic. Ma'am, please.
Okay, okay.
Am I audible?
Yes, ma'am.
Is my screen is visible?
Yes, ma'am.
My slides are visible because I can't understand. Is my slides are visible, sir?
Slides are visible, but not the slideshow.
Not the slides, so okay, right. Just let me check. Just give me 1 minute. Let me see what happens.
Yes, ma'am.
Let's take a copy. Yeah.
Huh?
Now my slides are visible.
Slide is
Now
visible.
Yes, ma'am,
Yeah.
it's visible now.
Okay, thank you. Okay, a very good afternoon to all of you. At first, I want to convey my sincere thanks and gratitude to the organizing committee for giving me this opportunity to share my views. And special thank goes to definitely to Jui Datta, my friends. So today, next couple of minutes, I'm going to share with you the assessment of pain, which is very important. I hope all of you will agree that suffering can be avoided, but pain cannot. Pain is the things which changes a people. Some become rude and some become silent. And in the healthcare scenario, the pain changes the physiological parameters of a patient and it has lots of negative impact on the patient outcome. So being a healthcare provider, being a nurse, it is our utmost responsibility to manage patient's pain, and patient pain is considered as the fifth vital sign. That's the reason. Now, why? Why this pain management is so important? Pain is complex and common problem. At least 10% of the world's population is affected by chronic pain. 8 in 10 patients with chronic pain affected by severe depression. Pain is often under-recognized, leading to inadequate management. Untreated acute pain may lead to adverse sequelae. Opioid safety across the continuum of care continue to be a top patient safety concern. Now, we know that this pain management is mainly depends upon the pain assessment. Now, in this regard, I will recall again the most famous quote of the Peter Drucker that you cannot manage what you cannot measure. So we have to assess the pain properly, accurately, and then only we can manage the pain. And you know, what is this pain? Pain is a subjective, unpleasant, sensory and emotional experience associated with actual or potential tissue damage. It is multidimensional in nature, which affects the people physically, psychologically, socially, and spiritually. And that this pain actually is perceived by the patient. And that perception of the pain, we have to assess to manage their pain. That is very important. And what happens in pain? Pain occurs when a noxostimulus affects peripheral sensory nerve endings. And this electrical stimulus is carried to and from the spinal cord to the brain. And this stimulus is then interpreted by the brain, and then a reaction is seen from the central nervous system to the peripheral nervous system. It is just a bit. Now, there are different types of pain. Pain is categorized according to the duration, location, intensity, as well as the etiology. According to the duration, it may be acute, just a sudden pain, or it may be a chronic pain. Chronic pain is again further divided into the chronic non-cancerous pain, chronic cancer pain, and the chronic episodic pain. Based on etiology, pain is again broadly classified into two broad categories: nociceptive pain in terms of the somatic pain and the visceral pain, neuropathic pain in terms of the peripheral neuropathic pain or the central neuropathic pain. Based on the location, pain is again non-referred pain, means a localized pain. When a person is having some headache, stomach pain, or there is any abscess, that area tenderness, or there is the got injury in some soft tissue ligament. So that all those pain is called as a non-referred or localized pain. And there is another pain, this is referred pain. That means pain is felt by the person other than the injured or the diseased part. And very common, we have seen in our clinical experience, many times the patients with the myocardial infarction is coming and complaining the pain at the lower jaw or the back or the right hand or left hand. So these are called the referred pain. And look at this picture very carefully. We can understand all they are having the pain. But is there any difference? Definitely there is difference by their, we can understand the difference is nothing, it is the intensity. So based on the intensity, pain is further categorized into the mild pain, moderate pain, and the severe pain. Now, this pain assessment actually is a challenge for any of the nursing staff or the healthcare provider, because both there should be a mixing, there should be a matched the perception of the patient's pain, actual pain, and that perception should be assessed by the nursing staff properly. Now, what is the common practice? What we have seen, we are going to the patient and we are asking, are you having pain? How much is the pain? And initially, we have most of the hospital, we have seen the people are using this one of the scales which is having some indicator or cursor. So in my experience, I have seen, and so many times we have given to the post CABG patient, it is, I'm talking about the around 98, 2000 in that time. So we are giving the patient, and patient is trying to move the cursor here and there and trying to understand they're facing pain or not, which is absolutely wrong. So they are also not having the clear-cut conception how to grade the pain. I am having pain is something different, and how much pain I am having, that categorization is really a challenge. But that is very important, how much pain we are having, because the entire pain management based on how much pain a person is having. So there should be a systematic approach of the pain assessment. In many organizations, we follow a quest, like first question the pain patient is having any pain or not. Then use the pain rating scale, means how much pain the patient is having. But if the patient is telling, I am having this pain, back pain, or whatever the area I am having pain and this much of pain, don't be happy with that. Evaluate the behavior. That means to validate the patient's pain by the behavior and the other parameters. Say, for example, you are allocated nurse and patient is complaining, yes, I am having pain, back pain, and you are asking how much pain on the 0 to 10 scale. Patient is telling 6. And since morning, you are there with the patient and you are watching, the patient is comfortable, he is actively participating in your treatment regimen, looking at the TV or reading the newspaper or talking very quietly. So you have to understand there is some problem on the patient perception, or the clarity of the pain rating is not there. So whatever the pain the patient is telling, by perceiving and rating, that has to be validated by the nurse, by the physiological parameters and the other things. If the patient's family or significant others are there, that also has to be involved in this pain assessment or management process. Along with the assessment, you have to understand what causes the pain. That also has to come in account, and then the take action. So there are different systematic methods is there for the pain assessment, and very common is the OPQRST. I think all of you are following. So first, what we want to know the onset of the pain, when the pain occurs. What is the provocative factor of the pain? What is the quality of the pain? Provocative factor means when the pain occurs, actually what does the patient is doing in that particular time? Patient is sitting, or patient is walking, or patient is sleeping, or the patient is doing certain exercise or some emotional breakdown. So whatever, what is the reason? Quality of the pain, is it a dull pain? Is it a aching pain, or throbbing pain, or sharp pain, or stabbing pain? So we have to understand the quality of the pain. Then the radiation, or for radiation means pain is localized or is radiating to some another places. Already I told the myocardial infarction pain, not only the myocardial infarction pain, many spinal pains are also radiating in nature. So many times patient will complain, I am having a lower back pain, it is radiating to my thigh or to that. So that also you have to understand. Then the question is coming, the severity of the pain, means 0 to 10 scale, how much you are grading that pain, as well as the timings of the pain, how long it is there. One very popular mnemonic is the Socrates method. There also we are asking, or we are assessing the site of the pain, onset of the pain, character. The character means it is a sharp pain, aching pain, throbbing pain, spasmodic pain. What is the nature of the pain? Is it radiate? What is the radiating nature or not? Is there any associated symptom? Many times we have seen, again, the myocardial infarction patients, I'm giving an example, patients are coming with the chest pain along with the shortness of breath, and the profuse diaphoresis is there, vomiting is there. Many times the patient is experiencing nausea, vomiting just because of the pain. Then exacerbating nature, what aggressive, what is the things, it is the increasing the pain or the alleviating factor, that also you have to assess, and definitely the severity of the pain. Many organizations nowadays, they are using quiz-stepped mnemonic. Now, what is this quiz-stepped? We are assessing the quality of the pain, impact of the pain, what is happening because of the pain, what is the activity changes, what is the physiological parameter changes, everything we are assessing in that impact, site of the pain, severity of the pain, and temporal characteristic. Temporal characteristics means, is it a recurrent pain, chronic pain? If it is a chronic pain but fluctuating is in the intensity, so all those things is called the nature of the pain, also called as the temporal characteristics. Then aggravating and alleviating factors. And another very important thing is the P, quiz step. The P is past response. The patient, is this the first time the patient has experienced this type of pain, or the patient already had same type of episode of the pain, and what is his preference, what type of treatment that patient took, and it was patient felt comfortable. So many times patient will tell that you give me a hot bag or some cold compress or something. So that also you have to understand the patient's expectation, goal, meaning, and it has to be also validated with the diagnostic and the physical evaluation. To assess the pain, nowadays different tools are there, and we are using the different tool in different organizations. For the adult pain assessment, there are the very common some tools are numerical rating scale, visual analog scale, defense and veterans pain rating scale, adult non-verbal pain scale, pain assessment in advanced dementia scale, behavioral pain scale, critical care observation tool, pain observation tool. Now, this is a very common numerical rating scale where the pain is assessed on 0 to 10 scale. So sometimes 0 is no pain, 1 to 3 is considered as a mild pain, 4 to 6 is a moderate pain, 7 to 10 is a severe pain. It is very easy to understand, but this has to be understood by the patient. So enough explanation patient is required before the pain assessment, so the patient also can rate properly what actually we are understanding by the number. Now, visual analog scale, here the same on the 0 to 10 scale, but here we are assessing the patient face. So you can understand by seeing the face, this is no pain, mild pain, how the facial expression will be there. The same 5 to 6 is the moderate and the severe pain. In the very severe, and when the patient is crying, you can call as a worst possible pain. In many organizations, also it is been told the 0 means no pain, 1 to 2 is mild, 3 to 4 is moderate pain, 5 to 6 is severe pain, 7 to 8 is very severe pain, and 9 to 10 is unbearable pain, or you can call it as a worst pain possible. This is a defense and veterans pain rating scale. Moral is the same thing, but here the pain is again measured based on the activity. You can see 0 and 1 fine, when 1 is hardly noticed pain, 2 means there is a noticeable pain, but it doesn't interfere with the activities. When the patient is telling that because of the pain, sometimes patient is getting distracted. So that is the 3. Patient is getting distracted but can do the all usual activities. The pain is 4. But because of the pain, when there is some interruption in activities, pain is considered as a 5. Sometimes patient will tell it is hard to ignore. So, and they are avoiding usual activities. So pain is considered as a 6. Now, sometimes patient will tell continuously his or her attention is going on the pain and he is not doing the daily activities because of the pain. He don't want to move because of the fear of the pain. So the pain will be considered as a 7. And when the patient will tell it's very awful, hard to do anything. So it is a severe pain. 9 can't bear the pain, unable to do anything. And you know the 10 is the worst possible pain. So nothing can be done in that cases. Many times patient cannot express. So we have to understand as a healthcare provider about the pain. So that time what we are using adult non-verbal pain scale. So in this adult non-verbal pain scale, there are the 5 category, 5 area which are assessing, that is the facial expression, activity, girding the injured area or the pain area, physiological parameters, especially the vital signs, and the respiratory status. Now, if there is a very normal smiling face, so there is no pain. If the occasional grimacing, tearing, frowning, or wrinkled forehead, it is 1. If there is a frequent grimacing, tearing, so we call it as a 2. Same way activity, if the normal activity, normal position, 0, but needs attention, or the patient is having a slow or cautious movement, 1. Other patient is restless or excessive activity or withdrawing the reflexes, so we consider the patient is the 2, categorizing the 2. Guarding, if the patient is having normal, so no problem, but sometimes the pain, you will see the patient is continuously splinting the area of the pain, or tense, so this is the 1 will be validate, you will be giving the 1 point, and if this is rigid or stiff, the 2 point. Same way the physiological vital strain is the stable, so it is a 0. If there is any changes in the vital signs like systolic blood pressure is increasing more than 20 millimeter of mercury from the base, or heart rate is increasing more than 20 per minute from the base, 1. And if it is more than 30, systolic blood pressure increasing, or more than 25, heart rate is increasing from the base, we have to give the 2 point. Same way respiratory status baseline is okay, or the ventilator, the compliant with the ventilator, no problem. But if there is a respiratory is increasing or SpO2 is decreasing 5%, you have to rate 1, or respiratory rate increasing more than 20, or saturation is decreasing 10% from the base, we have to grade 2. So you see the here also the scale is on 0 to 10, and based on that our management will be there. This is the more or less same. This is the pain assessment in advanced dementia scale. There also we are checking the breathing, then the negative vocalization, facial expression, body language, or consolability. Facial language is like that. Breathing also, if there's a labored breathing, we call it as a 1. If the noisy breathing, we can consider as a 2. So if the vocalization patient is occasionally moaning or groaning, we call this, we just rate it 1. And if there's a repeated trouble giving or loud moaning or groaning, we rate it as a 2. So body position also like that, relaxed, 0, tense or distress pacing or forgetting, we give as a rate it as a 1. If the rigid or fist is clenched, so in that cases we score it as a 2. Consolability, this is very important because for the pediatric cases, lot of the time we will see the consolability. If there is no need to console, 0. If the distracted or reassured by the voice or touch, that means 1. And if the unable to console, so very difficult to distract or reassure, so we have to rate it as a 2. So here also you see the entire score is on a 0 to 10 scale, and we have to categorize the pain accordingly like that. Just we have to consider all these parameters, assess these parameters properly, rate the condition, and you have to score the pain. This is also another scale, that is the BPS, where you can see for the intubated patient and the non-intubated patient. For the intubated patient, we are checking the facial expression, movement of the upper limb, and the compliance. All those things we are checking. And for the non-intubated patient, facial expression, movement of the upper limb, but as here the patient is not ventilated, we are checking the vocalization. So by checking the behavioral pain scale, we assess the pain also in some cases. But the maximum and very common is the critical care pain observation tool. We are using the 5 parameters here also: facial expression, body movements, muscle tension, and compliance with the ventilator for the intubated patient, and the vocalization for the extubated patient. It is just right from the BPS only. Say, for example, the same, if the facial expression is relaxed, we call it as a 0, tensed 1. The grimacing, we are checking. Same with the body movements, we are checking the absence of movement. Patient is protecting the area or not, or the restless is there or not. So all are the 0, 1, 2. Muscle tension, if the muscle is relaxed, 0. If the tense or rigid, 1, and very tense or rigid, 2. If the patient is on ventilator, the patient is tolerating ventilator, 0, but coughing but tolerating, 1, but patient is fighting on the ventilator, so we have to rate it as a 2. But in case of vocalization, if talking in normal tone, no sound, 0, but patient is sighing, moaning, so we have to rate it 1. And crying out or sobbing, we have to 2, give it the 2. So you see Here also we have a 5 parameters, and our every parameters the maximum score is 2. So again the minimal possible score is 0 and maximal possible score is 10. And so this is also same. We have to have rate the scale on 0 to 10 parameters. Every parameters will be giving the rate, and if there's a based on the cumulative point, we have to do the pain assessment and pain management. See, this is the example. This is the same of the application of the CPOT scale, the critical care pain observation tool. You can see here that these 5 category, total score 0, no pain, 1 to 2 means mild discomfort, 3 to 4 is moderate pain, 5 to 8 is severe pain, 9 to 10 is unbearable pain. We will not wait for that definitely. So our management will start from 1 to 2 only. Coming to the pediatric pain assessment tool is another one more challenge, because many times people cannot, the pediatric patients, very difficult to understand the pain. Their response is different, but there are many tools to understand the pediatric pain, like NPAS, neonatal pain agitation and sedation scale, NIPS, neonatal or infant pain rating scale, neonatal facial coding system, NFCS, CRIES, FLAG scale, revised FLAG scale, non-communicating children pain checklist, NCCPCR, CHIOP scale, Wong-Baker scale, numerical pain rating scale, or the visual analog scale. Let's see few scale. So this is the NPAS, neonatal pain agitation and sedation scales, what we are using in our organization. So here, what are the parameters we are assessing? You see the thing here also we are assessing the on the 0 to 10. So let's see cry or irritability of the baby. If the baby is appropriate crying, means baby is crying when the baby is having soiling the diaper, or the baby needs the food or anything, so it is 0 and the baby is not irritable. If the baby is irritable or crying at intervals or but consolable, so there is a 1. But baby is continuously crying in high pitched or silent crying but inconsolable, so there is a, you have to rate it as a 2. Now behavioral, if it is appropriate for the gestational age, 0. If the baby is restless, is frequently screaming, so we have to rate it to 1. If there is a arcing, kicking, or constantly awake, or arouses minimally, or no movement, 2. Facial expression is very important, because our entire visual analog scale is based on the facial expression. So relaxed or appropriate is a normal, so it is a 0. Any pain expression, it may be intermittent, then also we have to rate it as a 1. And any pain expression continuous, we have to rate it as a 2. Extremity, relaxed hands and feet, normal tone, so 0. If there's intermittent clenched toes or fist or finger, so body is not tense, so we have to rate it as a 1. But if it is continuously clenched toes, fist or finger, and body is tense, we have to rate it as a 2. Then we have to again see the vital signs of the baby, especially the heart rate, BP, respiratory rate, and saturation. So if all those parameters are within the baseline or normal for the gestational age, 0. But if it is increasing 10 to 20% from the baseline and saturation 76 to 85% with the stimulation, so we have to rate it as a 1. And more than 20% increasing from the baseline and saturation is less than 75% and stimulation in the slow increase, so we have to rate it as a 2. So that is the rating system of the NPAS scale. Now NIPS, very commonly used in many organizations, neonatal infant pain scale. There also we are rating or checking the facial expression, cry, breathing, arms, legs, and alertness. If baby is relaxed, there is no cry, relaxed breathing, relaxed arms and legs, and sleeping, or the baby is calm, 0, no pain. But if the facial expression is contracted, or patient is mumbling or moaning, different excuse me, breathing is changed from the base rate, or arms are flexed or straight, legs are flexed or straight, or uncomfortable, every condition you have to rate it at 1 point. And if there is a vigorous crying of the baby, we have to rate as a 2 point. In the NIPS scale, maximum possible score is 7, and mild pain we consider as up to 2, moderate pain 3 to 4, and severe pain 5 to 7. Look at this neonatal facial coding system. By seeing the facial expression, we can understand the baby is having pain or not. If the baby is having in the resting condition, the facial expression will be like this. Look, this baby is also taking rest, but you can understand the baby is having the pain. Same in every cases, in the crying, the normal without pain, and when the baby is having pain, their facial expression got changed. This is another picture. The baby is crying with pain. We cannot see the picture, and the baby is here. Also, the baby is crying, but it is without pain. You see all this area, you can understand the baby is having how much pain. And really, it is a challenge for us to understand the degree of the pain. Cries, another neonatal pain assessment scale. Here also we are checking the crying of the baby, baby's oxygen saturation, baby's vital signs is increasing or not, and the expression as well as the hair also. Another one new parameter we are seeing, the sleeplessness. If everything is no problem, 0. If the baby is crying high pitch but consolable, 1. If the FiO2 is less than 30% requirement, 1. Heart rate or BP less than 20% increase from the baseline, 1. If the baby is gibberellizing, 1. But if the patient is sleeping but awakening often, 1. But the baby is inconsolable, FiO2 is more than 30%, heart rate or BP is increasing more than 20% from the baseline, patient is continuously grimacing and crying and constantly awakens, we have to rate it as a 2. And in this cry score, if the score less than 4, actually we are going for the non-pharmacological measurement of the pain management. But if the score increases more than 4, definitely we have to go pharmacological as well as non-pharmacological pain management process. Another one common scale many organizations are using, that is the FLAC scale. FLAC scale also we are seeing the baby's face, legs, activity, cry, and consolability. So if everything is normal, 0. If there is a changes, there is a restless baby or uneasy or little tense, or the baby is moaning or difficult to reassure, but after the assurance baby is easily consolable. So in all those cases we are giving 1. But if the baby is difficult, crying vigorously, kicking or arcing or rigid, steadily, it is kind of very difficult to console or comfort. So we have to rate it as a 2. In the FLAC scale also, our minimal possible score is 0 and maximal possible score is 10. There is also a device FLAC scale. In device scale, certain new parameters is added. Someone in the face, we are giving if the baby's face is sad or appears worried, we are giving 1. Or if the baby is distressed looking or expression of fright, so we have to give the 2. Like that, legs is the unusual, occasional tremor is there, we have to give 1. So entire thing is just certain other parameters is also added in this FLAC scale. That is why it is called as a device FLAC scale. Another one more scale. Here also we can see the same thing, like the vocal, the socialization, the facial activity, then the body and limbs, the physiological parameters, and the eating or sleeping. So everywhere you can say here the 0 to 3 scale we are giving and we are assessing, but it is not very commonly used in many organizations. But very commonly what we can see the NIPS scale, we can see the FLAC scale. Another common scale, the CHIOPS. There is the Children's Hospital of Eastern Ontario Pain Scale. Here also the same, we are assessing the crying, facial expression, verbalization, torso, as well as the legs. So if there is no crying, 0. If the baby is crying or moaning, 1. If the baby is screaming, 2. Smiling face, 0. If the neutral, 1, or the grimacing, 2. It is the basic principle is same in everywhere. Means we have to assess the baby's activity, baby's facial expression, baby's arms and legs and body, how it is it relaxed, or they are girding it, or there's stretching it, or if how the baby is crying, is the crying is normal, or is it consolable, or it is not consolable. What about the parameters of the physiological parameters? So everything we have assessed, and different scale is taken the different parameters or more or less the same parameters we can say, and they are rating it, and based on the rate we have to assess the quantity of the pain, and the management will be based on that. Very commonly used Buck-Baker scale, where we are seeing the facial expression and certain other things like no heart is a mild pain, is a moderate pain. So so many times the children also can tell, who the people who can tell, they are also the adult child, they can express their pain also. So Buck-Baker setting scale, same like adult, here also so many for the child, little bit younger adult child, we are using the visual analog scale. Another one, LIGO pain assessment tool, which you are using. The same you see, no pain, and certain things also is given like a for the assessor who is assessing the pain, alert or smiling, 0. There's no humor, serious or flat. There's a mild pain, but it pain can be ignored. But when the baby is frowning or the sad eyebrows or teared, so interfere with the talks, so it's called as a moderate pain. And intense, so it is when there's interference in the concentration, means the assessor when is talking, the assessor is no one, it is a nursing staff who are there continuously with the baby, or the caregiver or the parents, they can understand the baby is having pain. So by seeing all those things, so this is the unbearable pain or severe pain, and this is the worst possible pain. So there are many tools, there are many ways we can assess the pain. Now, why we are assessing the pain? Because we need to manage the pain. So pain management is a vast area. There are different approaches is there for the pain management. Initially, we start on the non-pharmacological management, distraction, and so many other things is there. Physiotherapy, exercise, lifestyle modification, your distraction. But many times, and mainly in the hospital setup, patient needs pharmacological management of pain. And this pharmacological management, again, there are a lot of medicines are there, the non-steroidal anti-inflammatory agents, simple analgesics, and we may need to start the opioid analgesic also. And already I told, opioid safety, always you have to keep it in our mind. So now patient will get what type of medicine? Many of the times, it actually depends upon our assessment. If we cannot assess the pain properly, if we cannot quantify the pain properly, so what will happen? Either pain management will not be proper, or the patient will get unnecessary extra drug which may not be required for the patient. And all the medication is having some or other side effects, but we should not give. Our patient safety is in our hand. Controlling the patient pain, giving the patient comfortable, keeping the patient comfortable is our responsibility and very important roles. So we have to assess the pain properly. Many studies proven that valid and reliable assessment of pain is essential for effective pain management. And pain assessment is the cornerstone to optimal pain management. So if we cannot assess the pain properly, we will not be able to manage the pain properly. But that is not our goal. Definitely our goal is that the patient who will come to us, we will be able to assess our pain properly. We will be able to make them comfortable, and with the minimal medication, maximum pain relief should be there by our approach, by our proper assessment. And I think we will be able to do so, and we are doing so also. So with this hope, I'm ending over here. Any question, any query? Thank you. So any query or any addition, any suggestion? You are most welcome. Can you hear me, sir?
No, ma'am.
You can't hear me?
Yeah. Pardon?
Can you hear me, sir? Hello?
Yes, ma'am.
Am I audible?
Yes, ma'am.
Okay. Any suggestion, any addition?
Ma'am, there are no suggestions from the participants.
Okay, thank you. Thank you very much.
Thank you, ma'am. Thank you.
Thank you, Champa.
Thank you. You're most welcome.
today program.
With this, we now move to our penultimate session on disaster management, which involves strategic planning and coordination to effectively respond to and mitigate the impacts of natural or man-made emergencies. It further encompasses preparedness, response, recovery, and resilience to our community safety and continuity of services. With this backdrop, I call upon Mr. Mahendra Singh, our next expert, to share his thoughts with us.
Thank you, sir, for giving me opportunity for a big platform. Good afternoon, everyone. I am Mahendra Singh, currently working at Dr. Ram Manohar Lohia Hospital. Today, I will be taking about two important and interconnected topics: disaster management and quality in healthcare. Let's start our discussion on how we can handle emergencies and mitigate emergencies and maintain high standard of care during the disaster. Golden words to say by: if you fail to prepare, be prepared to fail. Disaster management cycle. Disaster can be defined as any occurrence that cause damage, ecological disruptions, loss of human life, deteriorations of health services on a scale sufficient to warrant an extraordinary response from outside the affected community or area. It's defined by WHO. Then the four cycles of disaster: mitigation, preparedness, response, and recovery. The mitigations, pre-disaster mitigations involved effort, step to reduce vulnerability to disaster impact. Then the preparedness, education, outreach, and training, emergency management planning. It's under the preparedness. Response, immediate response to the all stakeholders like police, state disaster force, and all stakeholders in the response. The recovery, it's the fourth phase of the disaster and is the restoration of all aspect of the disaster impact. The points of disaster management in hospitals: emergency management, margin of error, resources to respond to a disaster, trained manpower in DRR, trained manpower in disaster risk reductions, coordination with stakeholders. It's a very important aspect, coordination with stakeholders, information management system, tackling emergencies, availability of the trials both on field and in hospitals, managing both external and internal disasters like fire hazard, terror attack, bomb cylinder blast, earthquake, mass casualty incidents, disaster specific treatment protocol. There should be a specified treatment protocol in every institute uh, for disaster management. Availability of the resources to refer and transfer critical patient. Availability of resources to transfer patient. Whenever we face any disaster, we have a volume of the patient too much, and many times our institute have not super specialty facilities or another thing. Then we should prepare always for the transfer the critical patient. So all equipment, including ambulance, is ready to move. A proper incident command center with designated incident commander to supervise the emergency. एक इंसिडेंट कमांड सेंटर इन एवरी इंस्टीट्यूट जरूरी रहता है, जिसमें एक इंसिडेंट कमांडर प्री डिजास्टर डिफाइंड होता है कि भैया ये इंसिडेंट कमांड रहेगी और इसका कमांडर ये रहेगा, ताकि वो उसको मैनेज करने में कोई प्रॉब्लम नहीं आए. स्टोरेज ऑफ डेड बॉडीज एंड इन्फेक्शन कंट्रोल. द मिनिमम मार्जिन ऑफ एरर. The SWOT analysis. The SWOT is a mnemonic. It's as for strength, weakness, opportunities, and threats. Quick prompt activation of incident command center. जितना जल्दी हो सके इंसिडेंट कमांड सेंटर को एक्टिवेट करना चाहिए, जिससे मैनेजमेंट में कोई प्रॉब्लम नहीं आए. इंक्लूजन ऑफ ऑल स्टेक होल्डर्स इन डिजास्टर रेस्पॉन्स, एस्टैब्लिशिंग प्रॉपर चेन ऑफ कमांड एंड फ्लो ऑफ इंफॉर्मेशन, रूटीन ऑडिट ऑफ ट्रेनिंग, रिसोर्सेज एंड मैनेजमेंट बाय emergency drills. Presence of secondary team to work in absence of primary. If any primary teams not available, then secondary team should be ready always. Available resources. Does the hospital have well-equipped ambulance? Hospital always well-equipped ambulance के साथ होना चाहिए. Availability of the resources for emergency providers like PP suit, gloves, sanitizer spray, machine, mask, emergency lights, etc. And availability of resources for disaster victims, life-saving drugs, medicine, transportation, tools, PP suits, masks, splints, bandage, etc. Firefighting equipment, disaster-specific resources for epidemic, helmets for earthquake, etc. Trained manpower, it's essential things. Always in every institute, trained manpower होना चाहिए disaster के लिए. It is the staff and all stakeholders trained in the basic of disaster management and DRR. Manpower trained in first aid and BLS and CPR, and manpower trained in handling firefighting equipments. Doctors and paramedical staff trained in the handling medical emergency during disaster and disaster medicines, field trials, rescue and recovery. Manpower trained in psychological first aid. Coordination with the stakeholders, how well connected is the hospital with both external and internal stakeholders? And external fire rescue, police disaster management, service, district disaster management, authority, etc. Internal incident commander, medical officer, officer in charge, on and off duty medical and paramedical staff. Is the disseminations of information follow hierarchy of the command and position and vice versa. Information management system. Presence of early warning system. Is the hospital well equipped with the information management systems? Does the hospital have a public addressal system? Presence of PR team and PR in charge. Effective coordinations with media outlets, print, internet, and social media. Right reporting of incident and error analysis. Always right reporting, and after the disaster, error analysis should definitely done. Any questions? Uh, any questions, sir?
No question, sir.
Okay, thank you.
Thank you, sir.
Presenting.
Thank you, sir, for your time. With this, we now move to our concluding session for the day, as well as for our webinar, which focuses on economic healthcare, which examines the allocation efficiency, cost effectiveness of resources in healthcare systems. It focuses on maximizing health outcomes while managing expenditure and ensuring equitable access to care. I now invite Mrs. Kalpana Lodhi for this presentation. Ma'am, please.
Good afternoon, everyone. Good afternoon. Thank you, June ma'am, and all the organizer for giving me the opportunity to speak on this national level webinar. Let me just share my screen. Give me a minute. And 2 minutes, please. Ma'am, there is a problem from my side. Can you share my slides which I have shared with you?
Yes, ma'am, you can start.
Ma'am, the PPT has been shared. You can start now.
Hello.
Yes, ma'am. Yes, ma'am. Now I'm able to start. Okay. Good afternoon, everyone. Sorry for the delay. So, start. Next slide, please. So, our today's topic is economic healthcare. We have gone through the various topics since last yesterday, and now we are going to end the webinar, and the last topic is economic healthcare. So today we are going to deal with the various strategies for reducing the cost in healthcare, but without compromising the quality of care. So what are these strategies? Let's see. So what are the things which we are going to cover on this presentation will be current financial landscape, brief overview of rising healthcare costs globally, what are the challenges of economic healthcare, what are the government initiatives, and why cost reduction is matter, why we are trying to reduce the cost, and what are the importance of cost reduction in healthcare, and what are the challenges in cost reduction, and what we can do, what strategies we can take in place to reduce the cost of these healthcare. So what is economic healthcare? So economic healthcare is an application of economic principles to analyze and improve the healthcare system. It focuses on how the resources are allocated and priced and consumed within the healthcare sectors. So there are certain key aspects which play their important role in this health economics. So what are these? Efficiency and effectiveness. What is efficiency? With minimal input, if we are going to generate the maximum output, we can say those measures are efficient. And effectiveness, when by using those measures, if you are able to achieve your goal or outcome, we can say those measures are effective. So efficiency, effectiveness, and the next component is affordability and access. And there are various stakeholders which take they play their role in this economic healthcare, and we need to include all those stakeholders while making the decision. Then only we will be in a place to provide economic healthcare. Next slide, please. So what is healthcare system? And we know the healthcare system is significantly dominated by the private healthcare, and they outnumbers the public healthcare in most aspects, including the services, hospitals, and doctors. We know what is the scenario in public hospitals and what is the scenario in the private hospital in terms of the services provided over there, and with respect to the manpower and all those things. And the next one is increase in public expenditure. So we can see the how government is increasing expenditure in the in this health sector. This corona has taught us a very good lesson. Before that, this sector was quite neglected, but now the government is also paying attention on our health sector. So if we can see the financial year of 2021 to how the public expenditure in healthcare is increasing from 1.6% to 2.1% of GDP. And as per the this economic survey 2022 to 23. And then if we see the government health expenditure in the financial year 2022, the government health expenditure in India was 845 billion Indian rupees. And the total health expenditure is expected to reach above 891 billion rupees by the fiscal year of 2024. Next, please. Next slide, please. Earlier one. Okay. So next we will see the overview of rising healthcare costs globally. Why the cost of healthcare is rising not only in India but globally. So the first cause is increased demand for healthcare services. Why this healthcare demand is increasing? Because the global population is growing and aging. Why this global population is growing and aging? Because of the advancement in the health technology and all those things, people are able to afford good quality of care, and in this way we are able to increase the life expectancy of the people. And when the life expectancy of people is more, definitely we will have a more aging people. And when the aging people is more, definitely certain health conditions are there which is related, which is associated with aging people. So there will be a higher demand for healthcare services, and this increased demand puts pressure on the healthcare system and contributes to the rising cost. And the second one is advancement in medical technology. So while advancement in medical technology have improved patient care, but on the other side, it often comes with the high cost, because nothing we can take without investing the money on that. So the new treatment or diagnostic method or medical devices, they can be expensive to develop as well as to implement. And this will contribute in increasing the cost of healthcare. And the third component or third factor is chronic diseases and lifestyle factors. So we know that now the demographic transition is there. Earlier there were more communicable diseases, but because of this demographic transition, we are moving towards the non-communicable diseases to the communicable diseases to the non-communicable diseases. And we know if we are suffering from any communicable diseases, one, we got the treatment and we will be okay very soon. But once you got the non-communicable diseases, for that you need to take treatment for rest of your life. So the consolidation of the healthcare. Oh, okay, it's at go. And the next point is administrative expenses. Administrative expenses are what? Expenses which like salary for the office people, cost related to the billing, insurance processing, and regulatory compliances. All these are the administrative cost, and these expenses contribute to the overall cost of the healthcare. And the next part, next factor is the drug prices. So the drug prices, the cost of prescription drug is rising with new specialty drug coming in the premium. So the pharmaceutical companies, they said they attribute this to the high cost of research and development, which the amount of money they have spent on the research and developing those new drugs. So initially they put high cost of those drugs, and after a certain period of time, then only we will get the opportunity to reduce the cost of those drugs. And then the next one is healthcare provider consolidation. Healthcare provider consolidations are what? When the hospitals, clinic, and other healthcare facilities, they join together by acquisition. So in that situation, that consolidation of healthcare provider can lead to the less competition and the higher prices of services, because they have the more power to negotiate. And the larger healthcare organizations often have more negotiating powers, which can drive up the cost. The next slide, please. Next, we will see the challenges of economic healthcare. So what are the challenges while dealing with economic healthcare? The first one is affordability. High cost of treatment and medication make it difficult for many of us to access the quality of care. We know our Indian population is now reaching more than 145 crores, and 27% of the population is under is BPL. They are not able to afford the healthcare facilities. So affordability is one of the challenge. And the second one is infrastructure gap. Infrastructure gap is what? There is an uneven distribution of medical facilities as well as the personal, and particularly in the rural area. We know government has made the norm ki every 5,000 population we should have a sub-center, for 30,000 population we should have a PSC, and more than 1 lakh or 1,20,000 we should have a CSC. But there is many discrepancies in these level of healthcare. If we have an infrastructure, we may not have a adequate number of health professional to for easy for smoothly running those institutions. And the next one is quality concern. Quality concern, we can see there is a variation in the quality of care across the public and private providers. And not only public and private providers, if you will consider a same institution, you will see the variation in the care. The care will vary from department to department. So quality concern is also one of the challenge. The next slide, please. Yes. So government has initiated many initiatives to overcome these problems. They have came up with many initiatives like Ayushman Bharat. This is the flagship scheme under the central government, in which the government is providing 5 lakhs insurance coverage for the BPL and EWS families. And the another one is NHM, National Health Mission. Earlier it was National Rural Health Mission, but that was covering only the rural population. Nothing is for the urban population. So they came up with National Health Mission. It focuses on improving the public health infrastructure as well as the service delivery. And the third one is Jan Aushadhi stores. Jan Aushadhi stores are what? They are offering generic medicine at affordable price so that we can reduce the reliance or expensive branded drugs. So there are various initiatives with which government is trying to overcome these cost related issues and make the healthcare affordable and accessible. Next slide, please. Why cost reduction matters? So the next question comes, earlier one, please. Yes. So why cost reduction matters? So for individual, it is different, and for society, it is different. So when we are considering the individual, why the cost reduction is matter? So the first one is affordability. Okay, lower healthcare cost make the treatment and medication more accessible. It is reducing the financial burden on families as well as the individual or the society, and this can prevent the people from delaying or foregoing necessary care due to the cost concern. And the second one is financial security. So the high medical bill can be financially devastating sometimes. When I remember when I was working in ICUs, I encounter many people. They said they have spent more than 3-4 lakhs in a private hospital. They have exhausted all their money, and now they are here in the government setup. So these medical bills are devastating for many people. So reducing the cost help people avoid medical debt as well as the financial hardships. And then the next one is improve healthcare outcome. So when healthcare is affordable, people will be able to avail these services. They will be able to seek preventive care, and we know early intervention can prevent the developing of the disease, and this can lead to a better overall health and the well-beings. If we consider for society, so the first one is sustainability. If unsustainable healthcare cost can strain on the national budget, reducing cost ensure the healthcare system remains financially viable for the future generation. And equity and access, when healthcare is more affordable, there is a greater chance for everyone to access those healthcare services regardless of their income level. Each and everyone from the various segment of this income level, they will be able to access these healthcare services, and in this way we can promote a more equitable services. And the focus on preventive care. So the cost reduction effort, why we are using this, they are often emphasizes on the preventive care, which can prevent expensive chronic disease in the long run, and this leads to a healthier population and potentially lower the overall healthcare spending. We know prevention is better than cure. And the next is the importance of cost reduction in healthcare. Why the cost reduction is important? So the first one is improved accessibility and equity. When the cost of care is less, people will be able to access these care easily, and there should not be any discrimination. It should be available for each and everyone. So it will reduce the financial burden on the families. It will reduce the disparity irrespective of when healthcare is more affordable, there is a greater chance for everyone to access those cares regardless of their income level, and we will be able to promote more equitable healthcare system. Enhancing public health and well-being by preventive care. Cost reductive efforts are often emphasizes on preventive care strategies. We know that, and this can identify and address potential health issues early on and preventing them from developing into expensive chronic diseases later. And this leads to a healthier population overall. And for better patient outcome, affordable healthcare allows people to seek treatment earlier, and they will be able to use those interventions and potentially better for their health outcome. And this will help in reducing the complications and the need for more expensive interventions down the line once if they got those chronic diseases. So next one is financial sustainability. We will be able to sustain financially sustainable by reducing the burden on individual. If the cost of medical care is high, it can be financially devastating for many people. Reducing the cost, it will help the people to avoid those medical debt as well as the financial hardship. And by reducing the burden on business, What does it mean? If the cost of healthcare is low, there will be a lower premium for the insurance, and we will be able to save money, and by this frees up resources of for the other investment, and potentially it will improve the employees' productivity due to a healthier workforce. And the next one is sustainable healthcare system. If unsustainable healthcare cost can strain the national budget, so the cost reduction ensures the healthcare system remain financially viable for the future generation, and allowing for continued investment in infrastructure and innovation. Focus on efficiency and values. So effort to reduce cost, it encourages a more efficient allocation of resources within the healthcare system, because if we are not able to allocate the resources efficiently, there is a chances ki we may waste our resources. So this can lead to a streamlined processes, reduce waste, and improve quality of care. And focus on value-based care. Focus on value-based care is what cost reduction initiatives, whatever we are using, they often push for value-based care model. Value-based care model is what, by by reducing the cost of care, if we are able to provide the quality care to the patient, that is value-based care. So which prioritize delivering the best possible health outcome at a sustainable cost, and this can lead to a better decision making and also eliminate the unnecessary low value procedures. So what are the challenges in cost reduction? If we want to bring the cost down, we need to face certain challenges. Without facing the challenges, nothing is possible. So the first challenge is what? Balancing the cost of quality. So if you are going to cutting the cost, there is a probability of compromising the care. So this point we need to make it clear that cutting the cost will not compromise it should not compromise the care. So a significant challenge is ensuring the cost cutting measure, it should not come at the cost of the decreased quality care. So this requires careful analysis to identify area for saving without sacrificing the patient safety or the treatment effectiveness. And the next one is stakeholder resistance. Stakeholders are what? Doctor, nurses, pharmaceuticals, and all those. So whenever the new change come into the force, definitely initially there will be a resistance. People are not willing to adopt those things. So the change management should be there by implementing the cost reduction initiative can be met with the resistance for various stakeholders within the healthcare system. Doctor, nurses, hospital, and pharmaceutical companies may be hesitant to change established practices or pricing structure. So there should be a change management procedure. And the next one is complexities of the system. So we know there are fragmented healthcare systems. They are often complex and making it difficult to identify and implement cost-saving measures across the entire system. And different providers, insurers, and regulations can create silos and inefficiencies in this. And the hidden cost and long-term impact. So focusing solely on the immediate cost reduction will not work out, because we may overlook the potential long-term consequences of those things. So for example, cutting the preventive care could lead to a higher treatment cost, which we are going to pay in the future once we got those chronic diseases. And the next point is data and transparency. So if there is lack of transparency in the pricing and the procedure across the healthcare system, it can make it difficult to identify the area of cost saving. So if there is no transparency, we will not be able to find out the area where we can reduce these costs or where we can save the cost. So inadequate data collection, if we are failing to collect the data appropriately, or we are not able to analyze the data, it will hinder the effort to track the effectiveness of cost reduction initiatives. So there should be a transparency. And then the technological advancements. So we know when there is a new technology, definitely it will offer the improved efficiency and treatment options. But their initial adoption can be expensive. Balancing the potential long-term benefits with the upfront cost require careful consideration. So what are the key strategies for the cost reduction? What we can do to reduce the cost? So addressing these challenges, they require a multifaceted approach. The first one is collaboration. So collaboration, we know there are various stakeholders involved in this healthcare sectors. So collaboration is must. So fostering collaboration between the different stakeholders in the healthcare system is crucial. Without their collaboration, we will not be able to reduce the cost of healthcare. And the next one is data-driven decisions. So we have gone through the previous lecture. There were one lecture on evidence-based practice. So evidence-based practice is what it is helping out us with making the decision best based on the data. So utilizing data analytics to identify area of waste and the insufficiency, it can provide valuable insight for targeted cost saving measures. And the focus on values. Shifting the focus towards value-based care, which emphasizes delivering the best possible health outcome at a sustainable cost and can improve efficiency and prioritize the essential services. And the next one is the investing in prevention. So it's better to invest in the preventive care instead of investment in the treatment or for their cure. So investing in preventive care and the health education, it can help to prevent the occurrence of chronic diseases in the long run. And because if once we have got those chronic diseases, the overall cost of treating those diseases will increase. So instead of investing in the treatment, we should pay attention on the preventive measures. So what are the key strategies for cost reduction? So we can lean healthcare. What is lean healthcare? It is a way of running healthcare services that focuses on improving efficiency, reducing the waste, and providing the better value for the patient. And it's aimed to eliminate the unnecessary steps and ensure that resources are used effectively to enhance the patient care. So by implementing these lean principles to eliminate waste, we can streamline the processes and improve efficiency. So the case study based on these lean healthcare, Virginia Mason Medical Center adopted Toyota Production System principle, and they have found significant reduction in the cost and improved patient outcome. The next measure is telemedicine and digital health. By using this telemedicine and digital health, we can reduce the unnecessary visit and the hospital stays, enhancing patient and monitoring and follow-ups remotely. Because once the patient is in the hospital, there we need furniture, electricity, and all those things which we can save if we are using these telemedicines. So there is a case study, Kaiser Permanente, extensive use of telehealth services. And what they have found, the reduced hospital visit by 26% and significant cost saving. So we can adopt this model. Next slide, please. The next measure is preventive care. So preventive care emphasizing on the prevention to reduce the incidences of chronic diseases like vaccination programs and regular screening. If we are using screening, we can identify those diseases at their earlier stage, and treating those diseases will be easier for us. So one case study was done on the diabetes preventive program, which were focusing on the lifestyle intervention to prevent type 2 diabetes. And what they have found, 50% reduction in the incidence of diabetes. So we can see the importance of preventive care. Next slide, please. The next measure is pharmaceutical management. So negotiating better drug prices and implementing generic drug use instead of the branded medications. We can go for the generic drugs because the cost of generic drug is lesser as compared to the branded medicine. So one case study is their Blue Cross Blue Shield study. They implemented the value-based drug pricing, and what they have found, there was significant saving and better patient outcome by using these pharmaceutical management. And the next measure is operational efficiency. Improving the supply chain management, and by optimizing the resource utilization, if we are going to if we are utilizing our staff, our equipment, whatever there, if we are optimally able to use those things, definitely we will be able to reduce the cost of care. So one case study is there, Cleveland Clinic. They streamlined their supply chain management, and what they have found, they were able to save the millions in operational cost. So we can go for this measure. If we consider the strategies for nurses, what we can adopt to reduce the cost of healthcare, the first one is effective care coordination. So why it is important? If we are coordinating the care efficiently, it will reduce the redundancies and the errors. For example, streamlining communication, optimizing workflows, and minimizing delays. Sometimes if we are not having the proper communication, proper delegation of the work to our subordinate, there is a probability of duplication of work. Next one is evidence-based practice. So evidence-based practice, we need to pay more attention on evidence-based medicine, because we will be able to find out which measure is cost effective and which is able to produce the more outcome. So we can go for that measure. So prioritizing therapy. Okay. Next one is patient education. So we nurses are at a place where we are getting the opportunity to spend more time with the patient, where there we can educate the patient about the cost saving measures, because patients are not aware about what is generic medicine and what are the branded medications. So we can teach them instead of the branded medications, they can go for generic medication. Where are these medications are available? All these education we can give to the patient, because they may have certain misconception related to these generic medication. They may think whatever is there on the prescription, they need to buy that medication only, and that is only the effective medication. So it is our responsibility to make them clear ki the action of generic drug or the branded drugs are same, and they can go for the generic medications. Collaboration work with the patient to make the collaborate patient also to make the informed decision. And the next one is the resource utilizations. So properly manage supplies and equipment and medications. It will avoid the wastage. We will be able to minimize the unnecessary tests and the procedures. And the last one is the advocacy. So advocate for the patient right and the access to affordable care. And also we can go for the system advocacy. We can promote cost-effective policies within the healthcare systems. So these are the strategies which, as a nurse, we can adopt. So in a summary, we have seen why the cost reduction is necessary. What are the effective strategies which we can adopt to reduce the cost of care? So there are various lean healthcare, telemedicine, and all those things. How to balance these things without compromising the care, how we can reduce the cost, what are the future directions, embracing the technological advancement, personalized medicines, and the integrated healthcare system is crucial. and government initiative and policy support are the key to driving these changes, because without government support or policy support, we are not able to bring these changes. And the final thoughts is sustainable health cost management ensures the efficient use of resources while maintaining the high standard of care, and prioritizing cost effective strategies and continuous improvement can better serve our healthcare populations. So this is all about my presentation. I have gone very fast because this is the lunch time and everyone is waiting for the lunch. So is there any question or any add-on from the audience?
No, ma'am, there are no questions.
Thank you so much.
Thank you, ma'am. Thank
Ma'am.
Thank you, Kalpana.
Thank you, ma'am.
Now I request Dr. Tanmay Ghatak, sir, to present Mrs. Juin Datta Ghosh with a token of appreciation. Now I again request Dr. Tanmay Ghatak, sir, present Mr. Manu Thambi with a token of appreciation.
Shooting Hima.
As we conclude day 2 of our national level webinar on quality in healthcare, I extend my heartfelt thanks to our esteemed speakers for their invaluable insights. I also appreciate the active participation of all healthcare workers, which made today's discussion so enriching. Special thanks to the organizing team for their seamless coordination. Let's continue to strive for excellence in our healthcare setting. Thank you, everyone.
Thank you everyone for the session. Today quality seminar was never thought of early. Jui came with the idea that we can do it, and we ultimately were successfully did that. It's a wonderful experience, all of, and it will continue the CME, the process will continue. Please, you all, requesting all of you, please do the post test so that we can come to know whatever help we are doing through this webinar. And secondly, the quality is coming in November, and we're hopeful that we'll be doing something for you for that, for those workshops, for those days also. Maybe a workshop 1 day or 2 day. Let's see. Thank you again, once again, all of you, and special thanks to Jui Sister Ji.
Thank you, sir.
Thank you.
So we